पता नहीं मैम, कुछ लोगों का खुल नहीं रहा है इसीलिए मैं पूछती हूँ। यहाँ पे हम लोग है ना, मैं यहाँ पे पूछती हूँ, पूछती हूँ मैं।
She has still
हाँ
time, na? So she can try, sir.
मैम,
Yeah.
योगिता मैम, सुचिता
Ah,
here.
yes, Suchit.
Ma'am, can I get the WhatsApp link because I have to share it with the MMC observer, or I have to
She can
tell him
join
to
through
register.
YouTube link.
There is no where.
YouTube link है ना? YouTube link है ना? मैंने share किया ना सारा ग्रुप में. She can join through YouTube link. Anybody can join through YouTube link. Free है ना वो सबके लिए.
Suchita, I think I had
I'll
वो
send
forwarded.
you.
मेल में ही है मैम। हाँ प्लीज सेंड
नहीं
ना
नहीं
मैम।
मेल में नहीं है WhatsApp पे है. I'll send you again.
ओके।
Deepa, do we have time?
Ah,
In
because I
another
can
five.
see just 19 participants. We'll just wait for a few more minutes.
Yeah.
हेलो।
Ah, Suchita,
हाँ
I'm
Hello,
sending you personal. You can mute Suchita by that time.
Yogita, do we have time
Yes,
still?
2
Hello,
minutes. Because ये 2 minute दिख रहा है मुझे अभी 6 o'clock के लिए.
try to log in through my laptop because I'll just leave
हाँ,
just
you
now.
relog in, no problem. You relog in.
मॅडम, ही लिंक बाकी लोकांना करू का? जे लोकांनी भरलेत पैसे पण सगळ्यांनी मला म्हणजे
They have to
त्यांनी
check
मेल
their
पण आहे त्यांचा।
emails.
मॅडम सगळ्यांना
I joined
सांगितलं
through that
त्या
email
लोकांनी,
only, na?
यू हॅव सक्सेसफुली रजिस्टर्डचा मेल पण आहे, पण सगळे आता मेसेज करत आहेत। आता 4 मेसेजेस आले माझ्याकडे
No, no,
की
they
तिथे
have to check their
ओपन
mails. It
नाही
it
होते,
is there
ओपन नाही होते।
immediately 10 seconds मध्ये येते Suchita. I could see I just registered
हो
myself five
आलंय,
minutes back.
मलाही आलंय, पण आता काय करू
They have to check
हेल्परचं?
their mails. No other way, nothing else. Don't worry. They have to see their mails well. So just message everybody, check your mails. One is that registration link, and then Zoom, they will see the Zoom message. It's there. Suchita, I
चेक
guess
युअर
we will.
मेल एंड क्लिक ऑन जॉइन मीटिंग लिखो ना।
Yes.
ओके फाइन।
Suchita and rest of you all new. Now we'll start. Good evening, all. I welcome you all. today's webinar on update in anesthesia for orthopedic surgery. This webinar is conducted by HBT Medical College and RN Cooper Hospital. So I invite Dr. Anita Shetty, madam, to speak about in details about this webinar. So Anita ma'am is past president of ISA Mumbai Metro branch. Currently, she is head of the department of anesthesiology at HBT Medical College and RN Cooper Hospital. So welcome, Anita ma'am.
Hello, everybody. Good evening. I would like to welcome. It's a great privilege to welcome everybody for this webinar on update in anesthesia for orthopedic surgery. So this webinar is organized by Indian Society of Anesthesiologists Mumbai Metro branch in collaboration of Department of Anesthesia, HBT Medical College and Dr. R.N. Cooper Hospital, and also Society of Anesthesiologists Maharashtra State branch. I'll just take a few minutes, like why we chose this topic is because the challenges of orthopedic surgeries are very unique. Because as you see, they can include patients from neonates to geriatrics, with multiple comorbidities. So that we have to tailor our perioperative care and anesthesia practice as per the case, and the complexities of the case are too much. So they can be simple elective surgery to emergency surgery. Though fractures can wait, they may not be life-saving, but they are limb-saving. So they have to be taken as early as possible. And that is why the first lecture is, when there is a fracture, it must be fixed. So, in spite of patients with multiple comorbidities, we cannot have time to optimize these patients to the maximum. So still we may have to anesthetize these patients. And of course, there are other problems like nerve injuries and how pediatric patients and how we take care of these patients in the ICU. So that's why it's not possible to take all topics in orthopedic surgery. We thought we'll just highlight few of the topics. And that's why we have taken 4 topics today. I will not waste much time, and I think we'll go over to Suchita to introduce the first speaker. Suchita?
Yeah.
You can introduce.
Hello, am I audible? Hello, am I audible?
Yes, yes.
Yes,
Suchita,
Suchita, you're
Yeah.
audible and visible as
Yeah.
well.
Yeah, I welcome everyone for this webinar on update of for anesthesia for orthopedic surgeries. Our first speaker is Dr. Harsha Narkhede. She is Associate Professor at PCPMC, PGI, YCM M Hospital from Pune. She has multiple publications on her name. She has written chapters in the book and also has been also won many poster prizes in the CMEs. She has special interest in the regional anesthesia with orthopedic and traumatic surgery. I hand over to Dr. Harsha to continue with the lecture. Hello.
Thank you for your time. Yeah, your screen is visible. Screen is. Thank you.
Thank you.
Thank you, Suchita madam, for the kind information. Before I start my talk, I would like to thank the entire organizing committee for giving me this opportunity to speak and be a part of this scientific session. So good evening, everyone. The topic of my presentation today. My slides are visible, no?
Yes,
Yes, you are visible.
Good evening, everyone. The topic of my presentation today is management of the orthopedic trauma. In spite of a development so much in our country, it's very disheartening to know the road crashes takes about 1.35 million lives each year around the world. And the major cause of this morbidity and mortality is attributed by the orthopedic trauma. So yes, this fracture should be typically addressed urgently. Whenever there is a fracture, it has to be fixed. But what is the stepwise approach to this polytrauma patient? We'll see one by one. The advanced trauma life guidelines emphasizes the approach by airway, breathing, circulation, disability, and the exposure. So as soon as the patient had a road traffic accident, within a golden hour, it should be shifted to the nearest multi-speciality hospital with the availability of the trained consultants, USG, and the X-ray. Now, with the availability of the USG, an anesthesiologist itself performs an e-fast in many centers. The stabilization of such patients initially includes the management of an airway, including jaw thrust, head tilt, insertion of the oral airway, check for the breathing, and if necessary, take the decision of the intubation, application of the cervical collar. Strictly shift this patient on a spine board to prevent the secondary spine injury. The tranexamic acid has been found to be beneficial in bleeding polytrauma patient when you start the dose within 3 hours from the injury. The dose is 1 gram over 15 minutes and 1 gram over next 10 hours. There is a damage control resuscitation concept for this polytrauma patient, which means you have to transfuse the RBC to maintain the oxygen carrying capacity and the transfuse the coagulation factors to prevent the coagulopathy in such patients. That means you have to transfuse 1:1:1. That is 1 RBC is to 1 FFP and 1 platelet. The activation of the massive transfusion protocol with the collaboration of the blood bank should be present in every hospital. Never miss the delayed signs of an polytrauma. The patient may be bleeding internally, or you can have a myoglobinuria. The patient is desaturating, then you can think of the fat embolism. So prioritizing the trauma care according to the elective, emergency, and the urgent basis, the polytrauma patient has been best approached by the damage control resuscitation protocol. If there is a neurovascular compromise or if there is an open fracture, it has to be addressed urgently, and the hip fracture has to be fixed as early as possible within 24 to 48 hours if the patient is stabilized. So after the stabilization and the resuscitation of this patient, we can think of an fixation of such fractures. The choice of an anesthesia depends on the multiple injuries the patient has, the patient cooperation, positioning intraoperatively, hemodynamic stability, intraoperative expected blood loss, presence of coagulopathy, pain control strategies, preoperative neurological deficit, and the application of the tourniquet. We'll see the upper extremity trauma first, which includes the clavicular fracture, acromioclavicular joint, shoulder dislocation, and the humerus fracture. We'll see one by one the clavicular fractures. The challenges in clavicular fracture is that there is a significant perioperative pain. There, the area supplied is very complex, supplied by the clavicle. The commonest injury is the mid-clavicular injury and is most of the time associated with a brachial plexus injury or the associated injuries of the chest and rib. The general anesthesia is always there, but the Divan Rian et al. Recently reported that the clavicular fracture surgery we can manage safely and effectively with a combination of the cervical plexus block with an interscalene block. While the Divan et al. To avoid the complication of the interscalene block has reported the management of such patients with a combination of the supraclavicular nerve along with an C5. Shoulder dislocation patient, they are again in an excruciating pain. We have to immediately relocate the shoulder under the procedural sedation, or there is an option of an intra-articular injection of a local anesthetic, which is less commonly practiced, or the low-dose interscalene block has been shown to have a reduced length of and stay in an emergency department of such patients. So all this shoulder surgery, the surgeon prefer the beach chair position to have the accessibility to the shoulder. So that so in this beach chair position, we have to keep in mind that you have to prevent the pressure related injuries and avoid the extreme position of the head to compromise the cerebral vessel supply. And you have to monitor the PP carefully in reference to the level of the brain, as the brain is at the higher level than the heart. And we know that every 1 centimeter rise, there is a 0.575 mmHg drop in blood pressure. The most important thing we have to keep in mind before giving the beach chair position, patient has to be transfused adequately to prevent the hypotensive and the bradycardic events. So these mid-humerus and the elbow fractures, we have the approaches of interscalene, supraclavicular, the combination of the two, or the infraclavicular. interscalene block, we have to keep the probe posterior to the sternocleidomastoid, and you can nicely see the traffic signals appearance of an, I have already marked here, C5, C6, in between the anterior scalene muscle and the medial scalene muscle below the posterior border of the sternocleidomastoid. So here lies the interscalene groove where you can inject the drug and block the C5, C6. Supraclavicular block, where you have to keep the probe above the supraclavicular fossa, and the brachial plexus has been nicely seamed as a grape appearance posterior-lateral to the subclavian artery. All these elbow surgeries and the mid-humerus surgery we perform in a lateral position, and as an anesthesiologist, we again have to pad the pressure points adequately to mitigate the nerve-related injuries such as the sciatic nerve, peroneal nerve. The cervical spine should be in stabilization with a thoracic spine, and the dependent eye and the pinna should be adequately supported, and also the axilla. The lateral position in we have to keep in mind that if the surgery goes very prolonged, then the patient becomes uncomfortable, and if you have to give the general anesthesia, then the airway access is difficult. Infraclavicular block. The position for the infraclavicular block, the arm is abducted and externally rotated. This is one of the deeper block, has to be given by the USG guided or the given by the dual guidance, USG as well as the peripheral nerve stimulator. You can see here the pectoralis major muscle, below that the pectoralis minor muscle, and the axillary artery, and the three cords surrounding the axillary artery in between the artery and the vein. Because of the pectoralis major and the pectoralis minor, it is a very good site to put the catheter, as it helps in a proper fixation of the catheter, and you can help in a post-operative pain, management of the post-operative pain. Fracture distal to the elbow, we have the options of an axillary block where you can keep the probe in an axilla, and you can block the individual nerve around the axilla. The ulnar nerve is between the artery and the vein, and there is an sorry. The musculocutaneous nerve is nicely seen in between the bicep brachii and the coracobrachialis muscle as in fish mouth appearance, and all the individual nerves you can block by 2 to 3 ml of the drug around the axillary artery and vein. So these individual nerve blocks, where you can have the for the radial nerve block, you can have the probe position over the mid humerus, and you can see the radial nerve above the humerus. Then you can have the median nerve in an forearm, the nice honeycomb appearance you can see, and the ulnar nerve, and again in the forearm you can see along with an axillary artery and the vein. So when you scan it more proximally, you can have the only ulnar nerve, and it was separated from the axillary artery, and you can block the ulnar nerve at this position. But these blocks are less commonly practiced, but you can have as a rescue analgesia techniques when you give the supraclavicular or the infraclavicular block. So after the interscalene block, the incidence of the blocking of the phrenic nerve and the hemidiaphragmatic palsy is almost 90 to 99%, and it is a problematic if the patient is already respiratory compromised. But in one recent report, they have reported the successful management of such respiratory compromised patient after the interscalene block with the CPAP mask, so that we can avoid the general anesthesia. You can have the different blocks to avoid this complication, as in supraclavicular axillary nerve combination, ultrasonography guided erector spinae block at the level of T2 and T3, and the costoclavicular block. What is important in all this is preoperative documentation if the neurodeficit is present, and written valid informed consent with the patient before giving the regional anesthesia. So the clavicular fracture, as we know that it is associated with an brachial plexus injury, the mid-shaft humerus is associated with an radial nerve injury, and the distal radius fracture is associated with a median nerve injury. The problem after giving the regional anesthesia in patients of forearm fracture and the proximal tibia fracture is that the many case report, many anesthesiologists think that it can mask the symptoms of the compartment syndrome. But the recent case report suggests that that the appearance of the breakthrough pain or the increasing severity of the pain, even after giving the regional anesthesia, should not miss the diagnosis and which needs an urgent attention to prevent the permanent neurological damage. So the newer blocks in a regional anesthesia is one of the block is the costoclavicular block. Here you can see the costoclavicular place. In below the you have to keep the probe above the clavicle, and below the subclavius muscle you can see all the cords. They have nicely clubbed together. At next adjacent to the axillary artery. So here you can inject the drug with a single injection and the low dose techniques. In comparison with an infraclavicular fossa, where it is a deeper block and all the cords have been should be blocked separately. There is an SETB block, selective trunk block, which is described by the Tong and the colleagues, in which we perform the upper and the middle trunk block with the interscalene approach and block the C5, C6 nerve, and the C8, T1 is approached by the supraclavicular approach. Here you have to fix that the subclavian, there is a corner pocket is there in between the subclavian artery and the first rib. So even after giving the supraclavicular block, if the drug doesn't reach here, then it can spare. There are the chances of sparing the C8, T1 block. There is another scut block that is a site-specific regional anesthesia strategy in which you can see the hypodense structures in between the layers of the deep cervical fascia and the prevertebral layer of the deep cervical fascia, where you can block the supraclavicular nerves with only 3 to 5 ml of the drug. And when the C5, C6 originate, you have to trace them distally, and where they form the upper trunk, you can again give the 5 ml of the drug. This strategy you can use for the clavicular fracture fixation. You have to remember that none of the upper limb blocks supplied the intercostobrachial nerve. So T2 area you have to be supplied always with always additionally in and surgeries of an upper medial and the posterior arm and the surgeries of the pneumatic tourniquet. For the lower extremity trauma, what are the challenges? As these hip fracture patients, these are mostly the geriatric patients. They have the multiple comorbidity. They come with an excruciating pain. You have to perform the surgery early as possible. Intraoperative, there is a greater blood loss. There is a use of a large volume of a cement for a fixation, which can have the bone cement implantation syndrome. But recent studies have reported that the ERAS protocol in management of such patients has shown and benefits in terms of early recovery and the shorter length of an hospital stay in such patients. So what are the choices of an anesthesia in management of such patients? The neuroaxial anesthesia with a post-operative peripheral nerve block is the choice of an anesthesia. And you have to remember that the patient undergoing hip fracture have the greater risk of death from the pulmonary embolism, which can be reduced with the help of the neuroaxial anesthesia. However, the general anesthesia is preferred if the patient is receiving the anticoagulant or if there is a prolonged procedure is expected with a major blood loss. So what are the different options of a neuroaxial anesthesia? According to the feasibility and the expertise, you can have the decision of choosing the patient for the neuroaxial anesthesia. As you can give the single shot spinal, you can give the low dose spinal, top up with an epidural. You can use the epidural volume extension technique. And recently now it is developed and 0.5% isobaric bupivacaine drug you can give, and you can block only those segments which are necessary for the surgery with a low dose. And the fractionated spinal has been found to be very beneficial and prolonged the spinal anesthesia after giving the fractionated spinal in this high-risk elderly patients and maintaining the hemodynamic stability. In a fractionated spinal, you give the 2/3 amount of the drug first, then wait for the 90 seconds, and then supplement the another 1/3 amount of the drug. Recently, we had a patient of an polytrauma which was diagnosed with a pulmonary embolism, almost 90% occlusion of the pulmonary artery, and the RVSP pressure of 48 mm of an Hg, posted for an PFN. We managed successfully with an isobaric bupivacaine 1.2 ml of the drug and supplemented with an epidural. The lumbar plexus block is also we can give for this hip fracture surgery for the post-operative analgesia of such patients. Here you have, again, it is a very deeper block, and hence there are the more complications. You have to give this block with a curvilinear probe, or you can have the dual guidance technique. You can stimulate it with a peripheral nerve stimulator. You can see here in between the transverse processes, the psoas muscle, and in the substance of the psoas muscle, there lies the lumbar plexus. This sign is known as the trident sign. These geriatric patients often hip fractures. When they come in an emergency department, they are in an excruciating pain. With the availability of the ultrasonography, now we can perform the femoral nerve block immediately to relieve the pain of such patients. The other options available, which we can give for the even for the positioning of the neuroaxial block on an operating table. The first is the fascia iliaca block, which is again the large volume block. The spread is indefinite, which most of the time include the femoral nerve, and there is a chances of an quadriceps weakness. There is another approach for this fascia iliaca block is a supra-inguinal fascia iliaca block. Here you can see the nice bow tie appearance in between the transverse abdominis internal oblique with the sartorius, and the drug spread is seen in between the fascia iliaca and the iliopsoas muscle. This suprainguinal fascia iliaca block blocks the lumbar nerves more proximally before the branches off, so found to be beneficial than the fascia iliaca block, but again there are chances of a motor block is there. So you can have the ultrasonography guided erector spinae block to avoid the motor weakness, and you can have the recent one, that is a pain block, pericapsular nerve group block, where you block the femoral nerve obturator and the accessory obturator nerve by the curvilinear probe. You can see in this diagram, you have to scan from the anterior superior iliac spine to the anterior inferior iliac spine up to the iliopubic eminence, and the drug spread is in between the psoas tendon and the iliopubic eminence. And recent randomized controlled trial has found that pain block is more beneficial for the pain relief of an elderly hip fracture patients. So positioning for these patients, it depends on the due to the CM and the need for an fluoroscopy, the operative leg is fixed, and the non-operative legs, the hip and the knee are flexed because the accessibility of the CM. Hip dislocation patient, again they come with a significant pain and the muscle spasm, which can be relieved with a procedural sedation, and you can relocate the hip. Procedural sedation enhances the muscle relaxation, decreases the pain, and facilitates the reduction. But recently, the Jadan et al. Reported that even if the USG is not available, you can give the pain block by the peripheral nerve stimulator guided. And here you can see the marking point. From the ASIS to the pubic tubercle, you have to mark the line, and 5 centimeter from the ASIS, you can puncture for the peripheral, for the pain block. And you have to avoid here the femoral nerve stimulation. For the knee and the lower leg fracture, you have the sciatic nerve block at the popliteal fossa. You can block this nerve. You can nicely see the artery, vein, and the sciatic nerve on the top of the vein. Here on the right side diagram, you can see it has already been branched into the tibial nerve and the common peroneal nerve. So you have to trace it more proximally and block there before it branches off. Always remember that the sciatic nerve, sciatic block, you have to supply it with a saphenous nerve block, as the saphenous nerve supplies the medial part of the leg and the foot. Arthroscopic surgery, again the challenging for the anesthesiologist, as they are considered to be an outpatient surgery. So we have to decide the appropriateness of the patient, and we have to decide the appropriateness of the patient and the appropriate anesthesia, so that they will have an uncomplicated post-op recovery with a minimal pain. The ideal anesthesia is spinal anesthesia along with a blockage of the saphenous nerve, or you can have an IPAC block along with a multimodal analgesia. IPAC is the infiltration between the popliteal artery and the knee capsule. The adductor canal block, you can see here, when you have to keep the probe over the thigh, and below the boat-shaped sartorius muscle, you can see the artery, and adjacent to it is the hyperechoic saphenous nerve. And you can block by giving the 10 ml of the local anesthetic for the post-operative analgesia. The ankle and the foot surgery you can supply always with an neuraxial anesthesia or the combination of the saphenous nerve block or the sciatic nerve block, or whenever it is more distally, you can supplement it with an ankle block. Pelvic fracture constitutes the pelvic ring, acetabular fracture, and the avulsion fracture injuries. That needs the rapid evaluation and intervention from the multidisciplinary team. They are associated with severe other injuries like a head injury, thoracic injury, intra-abdominal organ injury, and the other fractures. You remember that the mortality ranges from 5 to 15%, and hemorrhage is the leading cause of mortality in such patients. When this pelvic fracture patient comes in trauma centers, you have to approach by an advanced trauma life support protocols. Application of the pelvic blinder and the skeletal traction is indicated in with the IV analgesic supplements of the opioids and the ketamine. And if the response to an initial resuscitation, you can shift the patient for an percutaneous intervention and the contrast CT. But if they don't respond to the resuscitation, you should have the rapid intervention and input from all the specialties. Bedside USG should be done urgently, and patient should be shifted to the emergency laparotomy for an angiography and the embolization. There is a recent report by Menon et al. They have reported that the management of the percutaneous fixation of the pelvic fracture with a spinal anesthesia is found to be a safe alternative to general anesthesia. We know that the incidence of the deep vein thrombosis after an pelvic trauma is between the 35 to 60%, and early initiation of an thromboprophylaxis, depending on the stability of the patient and associated traumatic brain injury, is indicated. While here, the general anesthesia could be associated with a high rate of the thromboembolic events, we can manage patients with a spinal anesthesia. Spine injuries. The challenges are challenges in view of a significant blood loss. The procedure is prolonged. There are position-related complications, and the pain management is very complex. All the polytrauma patients should be assumed to have the spinal cord injury, and the more common is the cervical spinal column. The approach ERAS protocol approach for this patient includes the airway management that includes the direct laryngoscopy with a manual inline stabilization assisted with a gum elastic bougie or with a video laryngoscopy. Succinylcholine should be avoided for 3 days to 9 months. Blood pressure management, according to an American society, they have proposed that the mean arterial pressure should be maintained between the 85 to 90 mm of an Hg, and it should not fall less. Systolic blood pressure should not fall less than 90 mm of an Hg. The fluid management includes the intraoperative, there is a major blood loss. The instrumentation is also there. So we have to prevent the blood loss by the alternative techniques like an autologous transfusion, or you can give the antifibrinolytic agent. You can use the Jackson table so that the abdomen remains free and the epidural venous engorgement is less, which ultimately causes the less blood loss. Hypotensive anesthesia in spine patients is nowadays very absolute, and you have to manage these patients with a goal-directed fluid therapy. The multimodal intraoperative management of such patients that can which can prevent the neurological deficit, perioperative neurological deficit in such patients. That includes the MEP, SACP, and the EMG. Motor evok potential and the SACP, you can give the inhalational drugs, but you have to maintain the MAC below 1. For an EMG, you have to avoid the muscle relaxant. So intraoperative surgeon can test, and if there is a neurological deficit, if he founds, then he can adjust the position of the screw to prevent the iatrogenic neurological deficit. So eras of the spine surgery also includes the preemptive analgesia and the opioid sparing multimodal analgesia. Preoperatively, that includes the drugs like acetaminophen, gabapentinoids, and the regional blocks. Intraoperative, you can supplement with dexamethasone, dexmedetomidine, ketamine, and the NSAIDs along with an local anesthesia infiltration. Postoperatively, again, you can supplement with acetaminophen, gabapentinoids. The role of an NSAIDs is controversial, but there are randomized trials in which they have proved that the ketorolac use is found to be beneficial in the management of such patients. Regional blocks for the management of the spine surgery, that includes the erector spinae block, in which you inject the drug in between the erector spinae muscle and the transverse process, or the TLIP block, the thoracolumbar interfacial plane block, where you inject the drug, modified thoracolumbar interfacial plane block, where you inject the drug in between the longissimus and the iliocostalis muscle. But it has proved that the erector spinae block has found to have an improved postoperative QR-15 score at 24 hours and found to be beneficial in terms of the pain relief. Awake endoscopic transforaminal lumbar interbody fusion surgeries we can perform under unconscious sedation due to less duration of the surgery. There is a less blood loss, and we can have the problem for the postoperative management of such patient if there is an nausea and vomiting. There is another case report by Puneet Khanna in which they have found that in patients of an ASA class 3, we can manage these patients under an spinal anesthesia. The surgery for under an epidural anesthesia, the surgery was lasted for less than 4 hours. Here they managed the patients with a fluoroscopy guided epidural anesthesia along with unconscious sedation. Chest injury, the role of an anesthesiologist in a chest injury is again very important, as they come with an extreme pain. There is an inability to breathe, inability to cough. So there is an reduced pulmonary, reduced cough. So that it has an increased chances of an ARDS. So the multimodal pain, multimodal analgesia in case of this management is very necessary for the chest injury. Traditionally, we used to put the thoracic epidural anesthesia, which used to reduce the pain score, reduces inflammatory markers, improve the pulmonary dynamics. But now we have evolved from the thoracic epidural anesthesia to an thoracic vertebral anesthesia, where you block the spinal nerve as they leave the intervertebral foramen. And now we perform the erector spinae block and the serratus anterior plane block. The serratus anterior plane block is found to be beneficial when there is an positioning of the patient is not possible, and in a supine position you can perform the serratus anterior block by giving the drug in between the serratus anterior and the latissimus dorsi muscle. To summarize, for the management of this orthopedic trauma, the comprehensive multidisciplinary approach is needed. We have to prioritize the trauma care as an emergency, urgent, and the semi-emergency surgery. Vigilance for the delayed complication of the polytrauma should be there for the internal bleeding of such patients or the chances of an fat embolism. The documentation of an preoperative neurological deficit is medico-legally important. Regional anesthesia is preferred over a general anesthesia, and the opioid-free anesthesia, the site-specific analgesia have a role in preventing the post-traumatic pain. There is a minimal risk is associated with a regional anesthesia, and less than 1% of the patient experiences the neurological symptoms. So we have to start introducing more and more of a regional anesthesia in management of such orthopedic patients. Follow the ASRA guidelines if the patient is on an anticoagulation, and most of these patients needs an aggressive anticoagulation therapy. And the multimodal analgesia approach should become the standard of the care for the management of this orthopedic trauma. We as an anesthesiologist should always think of the risk and benefits of patients and before choosing the type of an anesthesia for such patients. Thank you.
Thank you, Dr. Harsha. Hello.
Yes, ma'am.
Can you just highlight something about the blood loss in these patients, trauma patients?
Hello. Hello.
Hello.
Can you,
Yes,
Harsha?
ma'am. Yes, ma'am.
Sona, your question.
Harsha, can you highlight how do you assess the blood loss in these patients?
Blood loss in a polytrauma patient. So the patient is bleeding, madam. Then you can use the role of tranexamic acid is there. So you can use the tranexamic acid for an like 1 gram within and 15 minutes of an injury. So and it should be supplied at 1 gram over an 8 hours, which can decrease the chances of an bleeding in such patients.
Many times you see the blood is not only on the patient but on the floor. So if there is blood on the
Yes,
floor,
yes,
they
ma'am.
have to consider 4 times blood, meaning blood loss. That is
Yes,
one of.
ma'am. And for that, you need the insertion of the arterial line and the CVP line, and the goal-directed fluid therapy is indicated. And you can monitor the patient, and bit-to-bit monitoring should be there for such patients.
No, and
How
one
long
more
do
thing,
you
yes, Sona.
continue, Anita? Huh?
No, I was saying as one more thing we have to keep in mind that the fracture, if they are not, the bleeding is not obvious, but there is a concealed bleeding. Like if fracture tibia, fracture femur will have almost 1500, fracture acetabulum
Yes.
will have almost 2 to 2.5 liters of blood. Even
Yes.
though there is no obvious bleeding, actually,
Yes.
they have already bled that much inside. So that should be kept in mind.
Yes, yes. And we have to take these patients only after the stabilization. That was the damage control resuscitation protocol.
No, that you said is stable, only after stabilization, Harsha.
Stabilize.
But
Yes,
there are
yes.
certain fractures like fracture femur. They say that they should be fixed as early as possible.
Yes, yes.
So what is the time limit for fixation of fracture femur? But I think that is the
So,
most
madam,
important fracture, hip fractures, basically.
Yes, ma'am. So what I've read that you have to fix these fractures as early as possible within 24 to 48 hours if the patient is optimized, if the patient is hemodynamically stable. Or if the patient is not optimized, you can wait at least 72 hours and you can do the investigations like 2D echo and optimization of such patient within that hour, and you can take the fracture femur fixation after that.
Okay, if these patients are on antiplatelets, suppose fracture, hip fracture,
Yes,
then
yes.
do we need to wait till that 5 days or 7 days?
No, ma'am. If the patient is on an
Regional
antiplatelet,
anesthesia then what about regional anesthesia in these patients of hip fractures?
so ma'am, you have to as we have to fix it as early as possible.
Yes.
You can prefer to have in general anesthesia, or you can put the insertion of an epidural anesthesia is there. You have to time the insertion of an epidural anesthesia and the anticoagulation time according to the ASRA guidelines. So you have to strictly follow the ASRA guidelines. So
No, we will follow the ASRA guidelines, but as you said, we cannot wait, Suppose if I am giving clopidogrel, I cannot wait for 7 days, okay? It's a hip fracture. So what
yes.
do I do then?
Then you have to go ahead with general anesthesia.
And another thing I wanted to ask you, if there is a patient of polytrauma with a head injury, okay? So how do we, so after how much time we can fix these fractures, a patient of head injury?
So the polytrauma patient and also the head injury, you have to stabilize the head injury, and as soon as the intracranial pressure is lower down, you can take up these patients for an fracture fixation. And also these patients need an aggressive anticoagulation therapy. Managed traumatic brain injury is there, then that delays the like starting of the anticoagulation therapy in such patients.
So within how many days or hours can you fix these fractures in a patient of head injury? How much time should we wait if there is a head injury?
Madam, it is if we can wait for 24 to 48 hours, and if there is a decrease of the cerebral edema and the intracranial pressure, then I think you can take up this fracture for a fixation.
Okay. Sona, any question?
I had the same thing. How long do you wait to optimize?
I can answer that question because that's in my purview actually.
Okay. Who is it?
Go ahead.
Urvi
So,
Awad?
yeah.
That else. Okay, okay.
Yeah, so basically these patients we have to apply the damage control orthopedics in our mind, right? So we have to know something called as a first hit syndrome and the second hit syndrome. So when the patient with polytrauma, head injury, chest injury, they come to us initially, if the inflammatory response is very high, they are actually cannot be taken only in the first 24 to 48 hours. We have to wait. However, if sometimes in most of the cases we need to stabilize head injury patients and chest injury patients at least for 10 days till that patient comes out of the inflammatory response syndrome, so the patient becomes safe for the major definitive orthopedic surgery without something called as a second hit syndrome that can happen to these patients. Polytrauma patients, they are like, they're full of these inflammatory mediators, interleukins, and, cytotoxins. So initially also we feel, shall we take this patient? No. Wait for 8 to 10 days. But if that fracture needs to be fixed and stabilized, then probably external fixators or splinting, all those minor things can be done in the first 10 days, after 24 hours. But major definitive, please wait for some time till you're pretty sure that yes, now the patient is out of risk and his inflammation has come down and we can go for a definitive repair.
Okay. And what about regional anesthesia in a patient with head injury? How long do we have to wait? Especially neuraxial anesthesia, if we want to give for fractures. How long do we wait after a head injury, after the patient has head injury, and he has to be fixed for fracture, okay, lower limb fractures. So
If the
how
patient
long
is
do we
having
wait?
Patient,
Yeah,
yeah, intracranial pressure is raised, then that is a contraindication for this
yeah,
surgery.
yeah, I understand. But so how long do we wait? Is it days or months do we wait before we
No, no,
can
no, no,
make
no, no,
it?
no. If the patient is GCS wise 15 by 15 and he has been asymptomatic in the sense there's no convulsion, no neurological deficit, nothing, we
But-
can take the patient up in 48 hours with risk, but we can't give neurological,
Neuraxial
anesthesia. Yeah,
Neuraxial
Yeah, that's
neuraxial
what
you
I
can't
said.
give. You have
Yeah.
to give general anesthesia, but there will be some risk which may need to be explained to the patient. But yes, we can go ahead after 48 hours.
Okay, okay.
Uh,
Yes.
Thank you, Arsha, for that great start. There is one question from the audience or the participants. Is that schooling should be avoided in cervical spine injury patient? Why it should be avoided? And why you have said for 3 days to 9 months?
So as there is an initial muscle injury, when you give the succinylcholine, there is a chances of an hyperkalemia, release of an potassium into the circulation. So that's why you avoid the succinylcholine in such patients.
Thank you. Urvi ma'am, are you there? Hello?
Yeah, I'm there. I'm there.
Yeah, ma'am, there is one question for you also. It's like they have asked, what about the orthopedic complications if we wait for 10 days?
Well, there may be some orthopedic complication, but survival and to protect life comes over a limb, I feel. So limb-saving surgery and life-saving surgery, we have to differentiate between the two and then go ahead. So I have one case which I'll be discussing in my own talk. So I think I discussed rather there or now.
There, ma'am.
Yeah.
There. Thank you. Thank you, Harsha. Thank you, Urvi ma'am. Should we go ahead with our next topic?
Yes.
I would like to call upon Dr. Harpreet Kaur Madan ma'am. Harpreet ma'am?
Yeah,
Yeah.
Swachita, I'm
Yeah.
here.
Yeah. Harpreet ma'am is additional professor at HBT Medical College and Cooper Hospital. Her special interest is in pain management, regional anesthesia. She is also a teacher for soft skill in medical education training. Her major, she is working as a pain clinic co-in-charge in HBT Medical College and RN Cooper Hospital. She is also a FAMER fellow. She's a visiting clinician in Mayo Clinic. She has multiple publication, more than 10 publications in the journals and also chapters in the book. She is also a senior associate editor in RIA Journal. So I welcome ma'am for her topic, as she has worked so much in pain. So her topic is nerve injury associated with total hip replacement surgeries.
Yeah. All right. So are you able to see my slides?
Yes, you are audible and visible, Hatha.
Okay, yeah, great. Yeah. So good evening, all. My topic is nerve injuries associated with the THR. So nerve injury is a relatively rare but yet a potentially devastating complication. One second. Potentially, okay. Yeah. It's a rare but potentially a devastating complication of the THR. It may cause difficulty with the post-op rehabilitation and the overall mobility of the patient. The reported incidence of nerve injuries associated with the total hip replacement surgeries ranges from 0.6 to 3.7%, with a higher risk found in the revision THR patients. These complications may also result in medico-legal consequences. So therefore, the proper assessment of the risk factors, knowledge of commonly implicated anatomical structures and etiologies, and application of preventive measures is important here. Nerve palsy may result from compression and tension to the affected nerve during the surgery via the surgical manipulations, the retractor placements, the tension from the limb lengthening, or compression from the post-operative hematoma. Our risk factors here are a pre-op diagnosis of a developmental dysplasia of the hip or post-traumatic arthritis, revision THR or previous hip surgeries, lengthening of the leg with greater than 4 centimeters, then cementless surgical technique. Though cement also causes compression and thermal injuries, but cementless fixation of the implant are in fact associated with a very high risk of nerve palsies. Other risk factors are female gender because they have a low a muscle mass and thus are prone for nerve injuries. And these patients are also, I mean, females are also prone to have DDH, developmental dysplasia of hip. Then the presence of spinal stenosis or lumbar disc disease, age younger than 50, and smoking. Most commonly, the nerves which are involved are the sciatic nerve, followed by the femoral nerve. So both these nerves are basically are mixed nerves. So they have sensory and motor. So thus they have sensory changes and weakness of the lower limb. The other nerves are the lateral femoral cutaneous nerve, then the superior gluteal nerve and the obturator nerve. So the pathophysiology. Nerve injuries can occur during the surgery due to compression, due to traction, ischemia, and or transection. So the neural compression affects not only the nerve structures, but also its vascular supply. It can occur intraoperatively with the improper patient positioning and draping or improper retractor placement, procedural hip dislocation, or in the setting of a developing hematoma. So special attention should be paid to the positioning part, and the lateral part of the knee has to be taken care of because the common peroneal nerve is there and susceptible to nerve injury because it lies quite superficially. So the post-operative nerve palsies are called neuropraxia because here the damage is done to the nerve, but without the disruption of the axon and the nerve sheaths. So following a neuropraxia, the nerve fibers remains in continuity and thus have the potential to recover. The first indication that a neuropraxia has occurred, or what we see, is that the post-operative motor weakness in the dorsiflexion of the foot. Then there is this direct neural transaction or laceration commonly seen after the direct trauma by the instruments like scalpel, the electrocautery, the reaming of the screws or the other implant or procedure equipments, including the sutures. The risk for transection is highest in nerves that have tightly packed fascicles, such as the common peroneal nerve, Whereas the multifascicular nerves, like the tibial nerve, which has abundant connective tissues, are less vulnerable to injuries. So the etiology would be that during the THR, the lower limb is manipulated and the tissues are stretched for exposure, placing the tension upon the nerves. Specifically, the act of dislocating the hip may cause tension or compression of the nerves. So flexion of the hip and extension of the knee has found to increase the tensile strain in the sciatic nerve, and that leads to a significant increase in the intraneural pressure. The placement of surgical instruments is in proximity to neural structures. Like acetabular retractors may impinge upon the femoral nerve anteriorly or the sciatic nerve posteriorly. If you see on the acetabular rim, and the femoral nerve and the sciatic nerve are almost just 2 centimeters apart. I mean, from the limb, from the rim. So depending on the incisions of the THR, these are the nerves which get compressed. So on the direct anterior approach, the lateral cutaneous nerve is involved the most, followed by the femoral nerve. On the lateral or the lateral or the anterior lateral approach, the superior gluteal nerve gets involved. Posterior approach, the sciatic nerve, followed by the sciatic nerve, in which the common peroneal is the most commonest one. So a bit about each nerves here. The sciatic nerve exits from the pelvis, exits the pelvis via the greater sciatic nerve, anterior to the piriformis muscle, and then branches into the common peroneal and the tibial nerve. But there are some variations in the sciatic nerve where sometimes the common peroneal nerve also branches much more proximally and exits from the piriformis muscle. So there again, that nerve can also be compressed. The typical presentation of sciatic nerve would be a foot drop with weakness of the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. Eversion with the peroneal muscles is also seen here. But the tibial nerve is generally not involved. So the tibialis posterior, the gastrocnemius muscle, and the soleus muscle continues to do their normal function. Sensory deficits in the skin area supplied by the peroneal division, that's the dorsum of the foot and the first web says it happens here. So because of this weakness or the inability to dorsiflex the foot, patients may be unable to clear their toes from hitting the ground, causing them to trip. So here they use this ankle foot orthosis. Orthosis is a brace that maintains the ankle in a neutral or a dorsiflex position, which is necessary to prevent the contracture of the Achilles tendon and to aid in walking. The other nerve which is involved, or the second most common nerve, is the femoral nerve. Femoral nerve travels distally from the abdomen into the pelvis, anterior to the iliopsoas muscle and inside the femoral triangle. So this triangle, this lacks elasticity, so making the femoral nerve particularly vulnerable to prolonged hyperextension. That's the first thing. Second thing is iliacus hematomas, especially occurs in patients on anticoagulations. Third thing is using the anterior acetabulum retractors during the anterior or the anterolateral THA approaches. The clinical features here would be that patient may have a weakness in the quadriceps and the iliopsoas muscles with sensory loss over the medial pelvic and the anterior thigh. Patient will also have difficulty in walking and activities that require the quadriceps function, especially climbing up the stairs. The third nerve is the obturator nerve palsy. This is comparatively quite rare, but the nerve course would be that the obturator nerve descends through the pelvis, transects the psoas muscle major, psoas major muscle, then passes medially into the pelvic brim before exiting through the obturator foramen. So the risk factors for obturator nerve palsy include a violation of the anterior quadrant or the floor of the acetabulum. The features here would be that the obturator nerve injury is typically present as a medial thigh paresthesia in the groin pain and also adductor weakness. The other nerve which is seen is the superior gluteal nerve. It's a branch of the sacral plexus that originates from the dorsal division of the L4, L5, and the SY nerve. It provides motor innervation to the gluteus medius minimus and the tensor fascia lata muscles. So the superior gluteal nerve exits the pelvis through the greater sciatic notch, exits proximal to the piriformis muscle, and then branches into superior and inferior divisions before innervating the hip abductors. Injury to the superior gluteal nerve may occur if the gluteal medius is dissected 5 centimeters proximal to the greater trochanter. So the ligation of the ascending branch of the lateral circumflex femoral artery, that also causes a superior gluteal nerve injury. Then this presents with abductor weaknesses and Trendelenburg gait. So the lateral and the anterior lateral approaches of the incisions, those possess the greatest risk for the superior gluteal nerve injuries. So the prognosis here is much better than that seen with the sciatic nerve. The other nerve is a lateral femoral cutaneous nerve. So this originates from the posterior division of the anterior rami of L2 and L3. The nerve emerges from the lateral border of the psoas muscle, passes down obliquely along the anterior surface of the iliacus muscle. From here, it enters the lower limb by passing underneath the ASIS, approximately 2 to 3 centimeters medial to the ASIS. That is where we generally give the LFCN block. So within the subacute layer of the anterolateral thigh, the lateral cutaneous nerve also terminates as numerous small sensory branches. So this nerve supplies the skin of the anterior and the lateral aspect of the thigh up till the knee. It's a sensory nerve, so doesn't have any functional limitations. The injury seen is more with the anterior THAs, almost 15 to 81%. Other risk factors is hip resurfacing due to a larger incision required for this procedure. And LFCN compression is also called meralgia paresthetica. So the prognosis of these patients with nerve injuries and nerve compression is, it all depends on the initial neural insult, whether it was a complete or an incomplete injury, whether it was a traction injury, and certain patient factors, especially the BMI. So persistent dysthesias, that is a predictor of a poor outcome in nerve injury cases, and have been reported to occur in 28% of times. Few studies reported a worse prognosis associated with traction injuries and an increasing BMI. So isolated sensory neuropathies have shown a better recovery compared to those involving the motor branches, and incomplete palsies have shown to have a favorable outcome than the complete nerve palsies. Patients with early neurological improvements tend to recover more completely. So the diagnosis and the workup, the main thing here is your clinical diagnosis. Your most important thing is a well-documented pre-op and post-operative physical examination. The other test, what we use is EMG, the SSEPs, the measurement of NCVs, ultrasound or CT imaging for any hematoma compressions, and also MRI. Primary prevention is the key to avoid neural injuries and its potentially catastrophic consequences. Patients should be screened preoperatively for risk factors, especially the dysplasias of the hip and the previous hip surgeries. Surgeons should use caution and avoid improper positioning, excessive traction, improper instrumentation, and bone cement leakage. In high-risk patients, it may be beneficial to use intra-op SSEPs also to identify any neural compromise that occurs during the procedure. In the immediate post-operative period, radiographs are helpful in identifying the cement extrusions, the processes positioning, the inadvertent acetabular penetrations, all of which may lead to nerve injuries. Delayed nerve injuries can occur in the setting of scar formation or hematoma development, leading to compression injuries. And in the post-operative period, careful evaluation and patient education is important to ensure rapid identification of these potential complications. So the treatment here would be, so in case post-operatively patient complains of severe pain, then yes, the urgent surgical exploration is required. And also for hematoma. Hematoma usually presents as a delayed nerve palsy, but it requires prompt decompression. Other treatment would be a physiotherapy with the joint mobilization, extended bracing, and expectant waiting for the functional returns. Not time sensitive, and is the tendon transverse, because this is done usually after 18 months, allowing the maximum nerve recovery. So in the pain clinic, when these patients come, this is how we manage them. First thing is the medical line of management. The analgesics, the immunomodulators like pregabalins, gabapentins, the steroids. antidepressants like nortriptyline and amitriptyline, opioid or lignocaine patches, and analgesic gels or creams like a diclofenac gel or even a Gapapex ointment. Then we do aggressive counseling for these patients. And interventions, what we do is a dry needling. We do a USG guided dry needling. We do nerve blocks. Then the PRF of the pulse radio frequency of those nerves and radio frequency ablations also. PENG block, which is a relatively new block also. Now it blocks the hip articular ramifications from the femoral and the obturator nerve, and PENG block has shown good results. So to summarize, nerve palsy from the THRs or THA is a serious complication that leads to anxiety, concern, and potential agitations due to proximity of the nerves to the surgical site, manipulation of the leg during the procedure, or insertion of the surgical retractors, instruments, and post-operatively swelling and neuropaxia of the femoral or the sciatic nerve can occur. Also, palsies are slow to recover, so supportive care such as bracing, therapy, reassurance are the mainstay of the treatment. These are the bibliography. Yeah, thank you.
Thanks, Harpreet. Very
Yeah.
well presented. I just wanted to ask you, what about patients with comorbidities? Are they at increased risk, like diabetes,
Yes,
hyperlipidemia?
ma'am. Diabetes patients are at increased risk. Yeah.
One more thing, how do you differentiate? Like, if you have given a nerve block,
Yeah.
then how are you going to be safe from your side? What are you going to be?
Madam, we just some time back, I had a patient. I had given femoral sciatic for TKR surgery. So that patient came with a foot drop, So we started the analgesics, reassurance, the steroids also we had given. But generally, I mean, we told the surgeons that please, you also consider from your end, because it doesn't look like I mean, with the femoral sciatic having a complete foot drop. So when they did the CT and the MRI, they realized that the femoral, the common peroneal was stuck at was compressed at the fibular end, and they had to do the immediate surgery for the patients. Yeah.
So medico-legally, if there is a nerve block and you have given a regional anesthesia, okay,
Yeah.
and if there is a nerve injury, so medico-legally, how you protect yourself?
As I just mentioned, that we should have a well documented pre-op clinical examination.
No, pre-op is okay, but you have given a block.
Yeah.
And now the surgeons may say it's because of your block. So medico-legally, how do we protect ourselves?
Ma'am, if we are doing the surgery with the low dose, and I mean, if you're doing the if you're giving the block as an analgesic only, like 0.25% BUP, and ma'am, with a time wait, because if it's a block action, then the action generally wears off in a few hours.
And that's what even I wanted to ask. How do you differentiate? But I think so you can just say okay, our
And
block
the
should.
EMG and the NCV studies are later on done, but our block generally don't cause this. I've done a thesis on femoral sciatic, and none of my patient had any nerve compressions or injuries after the block, madam.
Do you have any suggestions how long we should follow up our patients after block?
Ma'am,
Once
we
you go,
generally follow the patients for 24 hours till the block action wears off.
there's a question in the chat box that if anyway there is nerve injury, why are you going to do a radio frequency ablation?
Yeah, ma'am, actually, I personally not got a patient of this, but we mostly do a PRF, pulse radio frequency.
Oh.
Hmm.
There is one more question. Is any effect of position during anesthesia on nerve injury, and how to protect it medically?
Yeah, I think that is what we've been taught from first year, that whenever we give the positioning to the patient from our end, like when we give prone or sitting or positioning, we always take care of the parts which are supposed to get more prone for injury. I mean, prone for the compressions, like the ulnar nerve in the elbow, or the common peroneal in the knee, or sural nerve in the ankle. So yeah, we always take care of that, right? Yeah.
Any more questions? Thank you, Harpreet ma'am,
All
for that
right.
excellent lecture. Ma'am, there are more questions?
Is only anesthesiologist responsible. Somebody asked,
Harpreet,
is it only
yeah.
anesthesiologist responsibility?
Harpreet ma'am, there is one question over here. Is the nerve injury, if it is there, is only anesthesiologist responsible for that?
No, no, obviously not. Yeah.
Thank you.
Yeah.
Thank
All
you for
right.
that excellent
Yeah.
lecture.
Thank you. Thank you.
Now we'll go ahead with the next topic. I will introduce Dr. Urvi Desai ma'am, who is a consultant in charge, trauma ICU and emergency, and also trauma OT at Sion Hospital. The
Hello,
special
everyone.
interest is the difficult airway management. She's a founder of a novel method of mass ventilation EP technique, and also has organized the first airway workshop in Jan 26 for PG students, and was faculty in the Sion Hospital. Her other interests are critical care and oncosurgeries. She is an eminent speaker in multiple conferences, especially the hip fractures and anesthesia in PGCon in 2017 and chest trauma in ICACon 2020. I will hand over to ma'am to continue with her topic of critical care in orthopedic and spine surgeries. Thank you.
I'm audible and my screen is visible. Okay.
Yes.
So, yeah, intensive care in orthopedics. When will our orthopedic patients require intensive care? Acute trauma. Some rare complications, fat embolism, of course, our geriatrics with comorbidities, spine surgeries, sometimes joint replacements, extremity surgeries, and definitely cement and critical care. So this is like a normal day in Sion Hospital trauma. We see every day patients coming with a fall from the railways, or, falling from height, crush injuries, falling from construction sites, and motor vehicular accidents with great collision, and patients having multiple fractures, and bleeding massively. And we have to follow, as said very nicely by Dr. Harsha, the ATLS guidelines. We have to see whenever a patient with orthopedic or without orthopedic injuries come to our ICU, you've got to do the air A, B, C, D, E. Take care of the airway if the poor GCS is there, manual inline cervical spine stabilization. You've got to keep in mind cervical trauma all the time unless it's ruled out. If the patient is not having a pulse, or is like, extremely pale, and just think about chest wall injury and all the fatal injuries that can happen, like flail chest, massive hemothorax, open neurothorax, tension pneumothorax. Okay, just a minute. I need to reduce this. Okay, fine. But so always remember that these patients who are hypotensive, they are hemorrhaging somewhere. They are either hemorrhaging inside, like in the chest or abdomen, hemoperitum, or they're hemorrhaging outside, like this patient, the picture which I showed with amputations. Or they are sometimes with so much massive trauma that they have pelvic fractures, and they're again hemorrhaging inside. So in the pelvic cavity. So at all times, I want to maintain, oxygenation, ventilation, perfusion, start the IV lines, and remember when you're resuscitating with the IV fluids and activating the massive, transfusion protocol, permissive hypertension should be in mind, because if you're very aggressive, you're going to dislodge the clot, and again, the patient is going to bleed. So when the patient comes to us, you've got to manually, till the orthopedic surgeons reach, manually try to control the bleeding, tourniquets and splints, and sometimes you may have to wheel the patient directly into the OT if he's bleeding very badly. Otherwise, we will lose our patient. When the patient is hemorrhaging, think about the triad of death. You've got to understand and remember there's going to be coagulopathy, there's going to be acidosis, there's going to be hypothermia. So at all times, A, B, C, D, E, whenever patient's condition deteriorates, yes, we have to take care of the airway and intubate. If the patient is stable, many times the patient may come with 1 or 2 limb fractures. In that case, in my ICU, have to take care of that pain also. Especially, I have children who come to my ICU with femur shaft fractures and they are crying in pain. So what do? I give pain relief, and I also give a femoral nerve block right there and there in the ICU, and they are relieved. Okay, coming back to our hemorrhaging patient, well, remember that we need to monitor these patients not only on the scope, on the monitors, but there are certain other things that we need to monitor, like our gases, like the lactate levels, like the urine output, like the heart rate. And accordingly, we have to transfuse the patient and keep the patient stable. Remember, A, B, C, D, E also includes X-rays, your USG fast, where you will have to come to some diagnosis to protect, to save the patient. If the patient is stable, then yes, a multi-trauma, a polytrauma patient, we do a full CT from buttocks to pelvis only if the patient is stable. Now, in this ICU, now the important question that was asked by the audience also was, when do we do orthopedic surgery? That there is a concept, this is a recent concept, damage control orthopedics, which has come in the 90s. What happened was, if the patient is unstable and you do a definitive repair, then definitely we are going to lose the patient. So damage control orthopedics tells us that for the first 24 hours to 48 hours, if the patient has been hemorrhaging, he's in DIC, he's requiring noradrenaline, he is requiring continuous inotropic support, then stabilize the patient. And if the fracture is open, or if there is an open pelvic fracture which needs to be further stabilized, then yes, we can go ahead with minimal external fixations, but definitive definitive repair of the fractures we'll have to take in once the patient is completely stabilized. Why? As I mentioned, there is a first hit syndrome where the patient sometimes with the polytrauma itself comes with severe ARDS, that immediately patient has to be intubated and put on ventilator, and then at that time we can't operate the patient. And then when we wait and stabilize and transfuse him and make him as physiological as before, then we go ahead with a fully definitive surgery for the orthopedics. Why do we need to wait for some more time? Is there something called as a second hit syndrome, in the sense that there is an inflammatory response which may occur in the next few days. So let's take care of all that and then go ahead with the definitive repairs. So I recently had a 35-year-old patient who was hit by a truck. Okay, he had multiple fractures. He had fracture of the femur shaft, he had open fracture of the humerus. He also had a thrombus in the femoral artery. So this patient, in spite of having a polytrauma, had to be taken in the OT immediately because of that thrombus. So the left femoral artery we had to do an embolectomy. And when we do a embolectomy, you have to do a definitive repair. So we had to do a left femur shaft definitive repair. And then we did an external fixation of his right humerus. He became stable. He was all fine. Next day, he was extubated. He was sent to ward. But exactly in 1 week's time, he came back to my ICU with acute renal failure, with MODS, and ultimately we lost the patient and he had to I mean, what this case is telling us that probably if his artery was not involved, even that femur shaft, we would have done external fixation or splinting or something like that till he became stable, and then we would have taken him for a definitive repair. Right? So this is one common cartoon. Like if you're not going to follow damage control of orthopedics, then you might as well have to do the CPR while you're fixing the fracture. There's another kind of acute trauma that comes in my ICU, and that is cervical spine injury. Okay, there are lots of young patients falling and fracturing, and it's and coming with severe spinal cord injury with quadriparesis, and it's very debilitating because they lose control and they're breathing, they go into respiratory failure, we may have to give oxygen, NIV, IPPV, they're in a lot of pain, so we have to take care of that pain also. And basically, if the orthopedic surgeons feel that this patient, most of the time we are bombarding these patients with methylprednisolone. Usually these patients are not taken up immediately, and only after 1 week, after the spinal cord edema settles, and if the patient has some recovery of, the neurological deficit, then they are taken up for fixation. However, the outcome is quite poor, and they really need palliative care in my ICU. Another, trauma patient that requires intensive care are these patients with femur fracture or pelvic fracture or tibia fracture, where it's a rare condition, but they come with you with sudden onset ARDS, with sudden, difficulty in breathing. They are confused and they have this particular rash, and that is the fat embolism syndrome. It also happens intraoperatively when they're reaming and, reaming with great velocity or overzealousness, and there's a wide gap between the nail and the cortex. Yes, we see such a case. It's rare, and the diagnosis is also out of exclusion. So there's a good criteria which tells 1 major, 2 minor of either confusion, tachypnea, and rash. The confusion is because of the cerebral involvement. The tachypnea is because of the ARDS. And you have these particular rashes as one of the important diagnosis. Now remember, these patients, the other minor criteria are tachycardia, sepsis, retinal involvement, anemia, thrombosis, lots of that, but you can pick one or two. The diagnosis is difficult because the diagnosis is fat in the pulmonary artery, fat in the urine, fat in the blood. So difficult to catch that fat. So therefore, if you see this fat embolism pictures, the patient presents to you with ARDS. If you do a MRI, which is the most diagnosed, there's a starry sign which you can see in the cerebral cortex. Okay, and this is a CT scan, which of course involves, shows you the plethora of the opacities which can be seen. Now, one of the most important differential diagnosis for FAS is, of course, pulmonary thromboembolism. So many of these patients are put to a CTPA, and then we can, differentiate that is it a pulmonary thromboembolism or no. But what is the management? How do we manage these patients? Well, of course, oxygenation, then, manage the hemodynamics. Sometimes they require inotropes, IV fluid, blood transfusion, start the DVT thrombo, the prophylaxis for DVT immediately. Adequate, maybe sometimes they require prolonged intubation, so nutrition, hydration. Okay, so this, mind you, that if this is a rare condition in ICU, but I have always seen the outcome is poor. I mean, I have seen that the patients don't come out and they have a mortality, how much ever we try. The next sort of patients who come to our ICU are the geriatrics with the comorbidity. They can't hide away from the ICU, but yes, they can hide away from ICU if we take care of their preoperative, stabilization and optimize them. So what's this thing about geriatrics? Like, they are so frail that you think trauma is a problem. No, even a haircut is a problem for them. they come to us like one package, okay? They're a bundle of stroke, IHD, COPD, ARF, alcoholism, delirium, malnutrition, you name it, rheumatoid arthritis. You got to deal with all of this when you're dealing with our geriatrics. So a little bit about the pathophysiology while treating them in my ICU. Yep, you must remember that their cardiovascular system is affected. They have stiff heart, diastolic dysfunction, they have low EF, they have poor baroreceptor reflex. So they may have a normal pulse and they may have a normal BP and they may be in severe hypovolemia, right? You won't even realize it. They have such a poor response to all our inotropes, and of course they're throwing all sorts of arrhythmias because of their degenerating conducting system. Another organ that we have to take care in all these patients is the kidney, right? They have their loss of cortical mass, they're diabetic and atherosclerotic and acid base imbalance, and they may have a normal creat, okay, but their creatinine clearance is very less. They have a decreased sodium reabsorption, they're hyponatremic, they're losing all their sodium and potassium. So these patients, again, they are prone to pre-renal ARF, UTI. Yep, and they have poor lungs, they have stiff lungs, they have stiff chest, they have increased closing volume, they decrease FRC, they could be having a patch, they could be having exacerbation of their COPD. They're very prone to post-operative respiratory failure, keep it in mind. And on to top it all, the geriatric patients, their brain, oh my God, that is also shrinking. They not only they can't see, they can't hear, they can't understand, there's cognitive disability. And maybe what may help over here is they also have less pain. So we never have to worry too much about pain relief in old patients. And most importantly, they could be preoperatively dementic, but they definitely go into postoperative delirium. So what do we do about this delirium? So keep a watch on geriatrics, because the moment you see that patients are delirious, okay, they may be septic, they may be having electrolyte imbalance, they could be having a stroke, they could be having UTI. So you have all these antenna up when you see a delirious patient. And how to prevent that delirium? Well, I would avoid anticholinergics, I would avoid opioids, I would avoid benzodiazepines. So preventive. Let's not make our geriatric patients more delirious. Yeah. So most common fracture, as she said, in all patients is the hip fracture. But if you look at the analysis, they have said that in spite of everything we do, they still have a mortality of 10% at the end of 1 month. And they still go into heart failure of around 60% and chest infection of around 40% and a DVT of around 4% in our patients on a monthly, if you take a monthly mortality, this infectivity rate. So what do we do? Like, let's start stabilizing them in the beginning itself. So I don't get their ICU admission at all. So take care of their anemia, their volume depletion, the electrolyte imbalance, control the diabetes. Arrhythmias can be corrected. Acute chest pain, start the antibiotics as soon as possible and take them in the operation theater. Most importantly, they will not come to your ICU if you give them regional anesthesia, if you give them peripheral nerve blocks. Right. So everybody knows that regional anesthesia is going to decrease DVT, going to decrease blood loss, it's going to decrease pulmonary complications. We're going to avoid opioids, of course, right? But again, regional anesthesia is when a patient becomes a difficult task. We may have to give general anesthesia to all our geriatric patients, and then they land up in the ICU in case of severe heart disease, or as madam said, anticoagulants, and we can't stop them, severe cognitive dysfunctions, recent head injury and stroke. So recent head injury and stroke and severe debilitation, yeah, there is no other choice but to give them general anesthesia. Right? So if I take care of my geriatric with whatever comorbidities he has in my OT, by keeping them warm, by taking care of their IV, putting a central venous line whenever. I remember I had this 100-year-old geriatric patient. The veins are so frail that I thought that maybe it can be done with the peripheral IV. No, you need to put in a central venous access, or we at least need to take a EJV. So we have a large IV, because even while giving a small bolus of IV, their veins fire. So small things we have to take care of our geriatric patients. Avoid glyco, avoid atropine, avoid midazolam, keep the MAP 60, and whatever anesthesia you're giving, you're giving spinal anesthesia, keep that volume less than 2 ml. You're giving general anesthesia, use etomidate, use desflurane, dexmedetomidine, use fentanyl. Don't use anything long acting. Keep the threshold for anemia a little high. Give blood transfusion to keep the HB 10. If you take care of these things inside the OT, then I don't have to take care of them in my ICU. However, if you see that picture over here, the horizon is never very clear when I'm dealing with geriatrics in my ICU. But when you see that bridge over there, that is my intensive care. After that bridge, it starts getting clear. So that is what I do. I take care of them, and then everything looks clear, and I want a happy old being. So how do I take care of my geriatrics who come in the ICU with a low EF? With an epidural? Yes, if there's an epidural, very good. If there is a low EF, what I do is I immediately do a heart scan. I immediately do a lung scan. I need to know the contractility. I will make sure that the anti-failure drugs are on. I'll make sure that the IV fluids are low. I do a POCUS IVC, SVC every 2 to 3 hours. So whenever I see a collapsibility, I'll give 100 ml of fluid bolus rather than giving lots of fluid throughout the night or throughout the evening. Okay. I have to start them on orals as soon as possible. No Dynapar for me in my ICU. I talk to them. I control the sugar. I take care of their warming and their air beds and all those things. And the only way I can prevent further problem is discharge them fast. When you do all these things, they get discharged out of your ICU fast and they are happy old beings, right? So another set of patients that do come to us in my ICU are those patients who develop some cement implantation syndrome. It's rare now because again, in the preoperative, we are very clear. Oh, if the patient has low EF, or the patient has got a very large heart, or if the patient has got some severe problem, we do an uncemented arthroplasty, correct? So this is all about hemiarthroplasty and cementing and the positioning of these old frail patients and how we take care of them intraoperatively. So what are the disadvantages when we use cement? Increase operative time and the risk of bone implantation, bone cement implantation syndrome. But why do you still use it then? Because of course it is a pain-free surgery. There is a better mobility and there is a reduced chance of reoperation. So what is this BCIS? It is a syndrome characterized by hypoxia and sudden hypotension, pulmonary hypertension, arrhythmias, loss of consciousness, eventually cardiac arrest, and all this because of the monomers which are released, and they can cause anaphylaxis, inflammation, pulmonary embolism, complement activation. So different grades are there. I have seen in my tenure as an orthopedic anesthetist, many times, when the cementing is going on, there is a fall in blood pressure, there is a transient desaturation, and then everything becomes normal again. So that is grade 2, grade 1. So grade 2 is a little more severe, where the saturation goes to around 85%, and hypertension is more than 20%. And grade 3 is cardiopulmonary arrest. That cardiac arrest I have not yet seen. Okay. So the incidence is around 25%, severe is around 5%, more so in patients with high ASA scoring and COPD. What do? What is the guideline telling you? Guideline tells us during cementing, take care of the IV fluid, keep your phenylephrine ready, keep the BP within 20%. All right. And if you have an arterial line, very good. Otherwise, keep your NIBP in the stat mode or every 1 minute mode. So you can, sorry. Okay. Right. So this is the another set of patients that come to my ICU, and these are spine surgeries. Now, when do we do spine surgeries? Spine deformities could be degenerative, infective, neoplastic, congenital, traumatic. Neoplastic, mostly neurosurgeons are doing, not orthopedic surgeons. What we are dealing with mostly are degenerative, the spine, patients who come to us. Congenital is kyphoscoliosis, and traumatic, as I said, fractures, right? So what we need to understand is many of the spine deformities can be conserved, but sometimes when the pain is too much and it's affecting your breathing and it's affecting your posture and it's causing neurological deficit, that is when we have to go for a surgical treatment, right? And the surgical treatment is to halt the progression and to improve the deformity. Okay, so when you're comparing the spine surgeries, as you go into more and more adult or geriatric, the spine becomes severe and rigid, and the soft tissue release becomes extensive, and the osteotomies become high grade, and there is a longer and longer segmental fusion. So, spine surgery patients coming to ICU are those patients who are old, geriatric, prolonged time, lot of blood loss, and they all come to our ICU. But remember one thing, when they come to ICU, it's a burden, it's an extra cost, it's a longer stay in the hospital. There's a chance of hospital-acquired infections, there's a chance of CLABSI, COTI, wound sepsis, all those things are there. So primarily, we need to control our admissions in the ICU by preoperatively stabilizing our patients. What are the different kinds of spine surgeries which we are doing? Lumbar discectomy, posterior lateral spinal fusion, anterior cervical discectomy and their fusion, and of course young kyphoscoliotic patients coming for their correction. Many times there's absolutely no problem, still they're shifted to ICU because of CSF leak, dural tear, cardiac complication, neurological complications. All right. So massive blood loss, high operative time, high ASA scores, high fusion risk scores, post-operative respiratory complications, cardiac complications, and neurological complications. All these things, in our spine surgeries, make them come into my ICU for further care. So this was one of the latest publication which says that whatever you do, these patients are definitely going to come in your ICU post spine surgery, that is BMI more than 28, patients with neuromuscular spinal deformity, ASA 3 and 4 patient, Cobb's angle more than 90 degree and more than 12 fused segments. If we are repairing, then yes, there is a higher chance for patients to come. Now, kyphoscoliosis correction, all our patients come in the ICU. Okay. And the important thing about kyphoscoliosis is that when these patients, when you're taking over of these patients coming to the ICU, you've got to understand, do they have any of these associated conditions? Like, are they having a cerebral palsy or muscular atrophy or muscular dystrophy or Duchenne's or Marfan's or neurofibromatosis, connective tissue disorders, syringomyelia? These are the patients who may develop complications like, post-op pulmonary complications may arise, or cardiovascular complications may arise, and may require more associated or more intensive care. One of the most important assessment of severity is, we all know, Cobb's angle more than 100 degrees. Yes, that is definitely going to affect your heart. That is definitely going to affect the lungs in such a way that when these patients are coming for kyphoscoliotic corrections, they would be having a decreased FEV1, decreased FVC, restrictive lung disease. They would be having a poor ABG. Their heart would be showing a pulmonary, moderate to severe pulmonary hypertension. If the patient has Marfan's, it could be associated MVP. The patient could be having a severe right heart, cor pulmonale with right heart failure. Right. So these are a group of patients which come to the ICU postoperatively, or another group of patients, like there is a lot of blood loss. Okay. Of course, we are managing the spinal cord perfusion inside the OT by SSCPs, MEPs, entropy, everything we're doing, but still there is a chance that the patient may have a compromised blood supply to the spinal cord and may develop a neurological deficit and come to our ICU. Extensive surgery can lead to hypothermia. That's why they're coming. But the important thing to understand is kyphoscoliosis is seen from 2 years to 18 years. I have done series of patients from 2 years to 18 years. And now with all these gadgets, all this monitoring, the use of TIVA, not using muscle relaxants, using only dexmedetomidine, propofol, entropy, most of the children are getting extubated on table because we are giving a good warming to the patient. We are analyzing the depth of anesthesia. We're also giving a good pain management. So the pain management starts in the OT itself. We're giving an ESP block, then local infiltration during the closure, which is given through layers. Sometimes we are also instilling the drug over the. You can't hear me? Am I clear?
You are clear. Somebody's
Okay.
unmuted.
I thought I got some disturbance.
Yeah,
All right.
you can.
So how do I manage my kyphoscoliotic patients is not only with the ESP block, but also a series of infiltration at different layers. I'm also giving paracetamol. I'm also giving opioid. And many times I'm also giving a fentanyl patch. Remember, in spite of all these things, they still have pain. And that's when I'm using the gabapentin, right? What I want to tell you is that kyphoscoliotic patients, in the OT, there is art line, there is central line, there is SACP monitoring, everything we are doing, but still there is a chance that they come to us for observation. And in most of the cases, I'm extubating. I had these two cases which I wanted to discuss. One was a case of an elderly, an adult actually 25 years with kyphoscoliosis with mitral valve prolapse with asthma. Okay, this patient, we had already explained to her that you may be a little dicey because the heart was showing moderate pulmonary hypertension. Still, we went ahead, but intraoperatively, we had to stop because she could not take it. She could not take any of that, the surgery or the blood loss, and we had to abandon the procedure. So it's very important to choose your kyphoscoliotic patient that you're doing. Another child which I had was of a spinal muscular atrophy, which I remember. Now that patient also we had excessively studied and preoperatively stabilized and spoke to the medicine and spoke to the parents and everything. And what was decided for this patient, because post-operatively, if he went on ventilator, then I knew that extubation would have become difficult. So for this patient, it was decided that we will do a stage operation. Okay. So when these conditions are there, we need to stage our spine surgery so that my patient is free of complications like a continuous ventilation and pulmonary complications. We don't want that. So this was where, again, we had an excellent outcome in my patients. Now, remember one thing, whichever cases we are doing and whatever cases require the intensive care, they come to me and we take care of them. But ICU is something that should be avoided. Why? Because it is in this ICU that I may get a CLAPSI, I may get a CORTI, I may get a wound sepsis, I may have a pneumonia, I may have a VAP, I may have a ARDS, I may also have sometimes bed sores in a patient with neurological deficit or prolonged ventilation. One more thing I wanted to add as a complication is sometimes we overdose our fentanyl in a geriatric patient. So keep the naloxone with you and always be careful about compartment syndrome. Keep on checking for the 6Ps, that is your pain, pressure, paresthesia, pulselessness, paro. All right. And I'm sure you're going to have a happy patient. Thank you. I'm free for questions.
Uh, Thank you, Dr. Urvi. Can you just briefly tell us about chest trauma?
Yes, of course I can tell you. I thought, all right. So
Please
when the
tell
patient comes with chest trauma to you, okay, you can see it in your inspection itself. Does he have bruising? Does he have any obvious, insult through the chest? Does he have absent breathing? Does he look blue? Is this vital? So immediately I need to percuss, I need to inspect, I need to auscultate, I need to put that oxygen, that monitor. And if I'm finding no breath sounds, no this thing, I have my USG with me. I immediately, we don't even wait for X-ray now. I just take my USG and check the M mode where the patient has, pneumothorax, and be ready to put in an ICD. Okay. If the patient is not having any of that, and still the patient is hemorrhaging, hypotensive, with the signs that patient has chest injury, rib fractures, pain in the chest, then yes, immediate X-ray chest has to be done to rule out hemothorax, because that is another reason where patients are, hemorrhaging profusely, and the treatment of most of the chest trauma is simply putting an ICD. So timely putting an ICD can save your patient with pneumothorax, can save your patient of hemothorax. You may have patients with no pneumo and hemo, but have multiple chest rib fractures. Now, those patients are the ones that over a period of time can go into a compromised stage with, what do you say? Atelectasis, consolidation, ARDS kind of picture. So those patients require excellent pain relief. We give them, we can give them epidural, but in my ICU, I was not giving epidural because there's a lot of coagulopathy going on, and and we have to shift the patient to OT and things like that. So fentanyl patch, maybe serratus anterior block, or maybe just opioids, paracetamol. These are the things we used to give to manage rib fractures.
I wanted to ask you if you're suspecting pulmonary embolism. Okay. So how do you diagnose it?
Well, now, if the
Because many
patient
times when
is,
there is hypotension, when there is hemodynamic changes, first thing we say the patient must be having pulmonary embolism. But it's not
right.
true. Many times patients do not have. So how do we diagnose?
So one of the best diagnosis, the gold standard, is to do a CTPA. If the patient is stable and his kidneys are good and he can tolerate the contrast, we must. If you are thinking, oh my God, this patient may be having showers of pulmonary embolism. If the patient is having moderate to severe pulmonary embolism, those patients are very classical. They will be collapsed. They will be requiring intubation. They're almost going to cardiac arrest like picture, right? So that is one thing, but the gold standard is to do a CTP. And if you can't do a CTP, like the patient is too unstable and you can't take the patient to CT, anyway, we have to start heparin for the patient. Okay. So either you start heparin, IV, or if the patient is throwing showers of emboli, just a small, then we can start low molecular weight also, BD. That is the dose which we are giving if you are suspecting pulmonary embolism. But the treatment is
No.
heparin.
No, there are two things. One is treatment is heparin, but the patient is immediate post-op. So will you give heparin or what do we do?
Yes, we can give. Heparin can be given immediate post-op also, because it is something that if your diagnosis is strong, if your suspicion is strong that the patient is having pulmonary embolism, yes, start the heparin. There is nothing wrong.
Will you do a DVT, this thing scan with the Doppler scan or something, USG? Just
See,
to
we
rule
can
out
do a
whether
focus heart. See, we
Yeah.
can pick it up on your ECG. Like there are lots of things,
Yeah.
there's a strain pattern seen, but they're very
No, they
crude.
may not be classical
Yeah, so
signs,
right ventricular hypertrophy, you can see a right ventricular failure. You can pick up on your focus and say, okay, yeah, I think no, this patient must be having pulmonary
No,
embolism.
another thing is, will you do a lower limb Doppler?
Of course, we have to
Or do you do a pre-operative? Will you advise all those immobile patients to do a
See, I
Doppler
used to
lower limb?
advise all the pelvic fractures with lower limb Doppler. Yes, definitely. Because where you're suspecting a very high chance of DVT, pelvic fracture is one of them. And post-operatively, nowadays the surgeons are very, they start
Conscious
Clexane
about it.
immediately. Like, within 24 hours they are starting. So post-op DVT, now the chances have become less. But pre-operatively, the patient is bedridden for very long time. Supposing he had the old fracture more than 10-14 days and he's not moved out of the bed, yes, you can demand for a Doppler. But nowadays, the surgeons like the low molecular in my ICU also, we are starting if the patient doesn't have any kidney injury, nothing, we're starting low molecular weight heparin immediately.
With
Within
immediate
24 hours.
post-op.
Like the patient comes and next day the Clexane is started.
Yeah. No, I was thinking if it's immediate post-op, suppose the patient has. Suppose it's
Clexane, no, we don't start Clexane immediate post-op, but heparin can be started, yes.
okay, unfractionated.
Unfractionated heparin can be started, ma'am.
Okay, and many times we have seen these elderly patients, now very old patients, like 80, 85-year-old. Their pre-op creat is still okay, but post-op, now many times they land up in acute kidney injury. So what are
Yes,
the precautions we should take? Because I've seen many patients going into
yes.
the rising
So I
creatinine.
will tell you there, first of all, their Dynapar NSAIDs is like a nail in the coffin, okay? So I avoid NSAIDs in geriatric patients. It's like the last thing you want to do. Second is that preoperatively, if you have an X-ray, USG KUB done, that supposing patient is diabetic for say 10 years, then please get a USG KUB done, because that will give you an idea whether the patient has a medico-renal disease. Even if it is grade 1, grade 2, whatever, even though creat is normal, but if the patient has a medico-renal, some medico-renal disease, which is picked up, then you know that I should avoid certain drugs. Like I should avoid amikacin, I should avoid levofloxacin, some antibiotics I will avoid. I will try not to infuse noradrenaline too much. Means see, NORAD again has been shown to increase the post-operative creat. So keep low doses. Supposing I need to give inotropes, but I will keep a low dose NORAD rather than a high dose NORAD for these geriatric patients. Then what else?
Yeah, because many of these patients, even if their creat is normal, so the creat will not increase unless there is 50 more, less than, 50 ml of fall in GFR.
Yeah.
So means
So
already
these
the
are the things like you should try to pick up that patient probably can go into post-operative, creatinine issue. Again, we have to remember that they are very geriatric patients now. If you give extra fluid also, their kidneys are hampered. If you give less fluid also, their kidneys are
Yeah.
hampered. So
So how do you monitor, how do you give the fluids? How do you guide your fluid therapy in these patients then? Is
so that's why
CVP
I'm saying
reliable?
in
So
my
you said we
ICU,
can take a central line. But
no,
is
in
CVP
my ICU, even if
reliable?
I don't have central line, what we do is the SVC, we do a subclavian vein collapsibility index, or we do a IVC collapsibility. I mean, that is a norm now. Like I need to know every 2 to 3 hours you got to. So I keep the geriatric fluid 1 ml per kg per hour. And and then see if the patient at the most 2 ml per kg per hour, but not beyond that. Beyond that, I will do a POCUS, and then I will see, okay, he is collapsing, I'll give 100 ml bolus. That is so little bit goal directed comes over there, rather than just infusing continuously 2 to 3 ml per kg per hour. No, they don't require that. And most of the orthopedic surgeries, they go oral. You start drink sips of water. They will say, and they have clinical signs, that you can see dry lips, dry tongue, they want water. So give them water. Sometimes very old patients, they don't have any of that sense. They have no sense of thirst, nothing. In that case, then you have to follow the routine. 5-6 hours ho gaya, bowel sounds have come, give water to the patient now. Start oral. Like let's put in eras for our old patients, and it really makes a difference. Like I discharge my old patients as fast as possible out of the ICU.
Yeah, everybody would like to, but sometimes I don't know, this patient is very difficult to discharge out of the ICU.
No, if they remain in the ICU, they're going to get a bug, and they get
that's going to get, but sometimes you have no choice. I think sometimes even they require very low dose of NORAD for 24 hours, 48 hours. These elderly patients, especially after regional anesthesia and all. Quite often we have seen that. So everything is normal. They're taking oral. Still, they are
No, I think then we must accept the MAP to be around 60, 70. Like accept the MAP rather than infusing with NORAD fluid. Give them blood. Sometimes they require albumin. See, these things are there which sort of makes them come out of that phase. Like giving that extra blood, giving that extra albumin, and they may just come out.
Okay. Any more questions?
Ma'am, what about the pre-op fluid for the geriatric patients? Because the NBM is almost 12 hours.
See, we are not supposed to keep it 12 hours.
Yeah,
Okay.
as per
But
the
this
new
occurs.
fasting guide.
You can at your own OT level, at your
Huh.
own level, you can tell them to drink sips of water. It's fine now. I mean, I know that you can't drink those complex carbohydrates. They're yuck. But you can drink water. I mean, that's fine. You need not have even appy and all those sugary drinks. All you can say is you can continue sips of water till 2 to 3 hours prior to surgery. Like fasting for 12 hours is a compromise we guys are doing because there's just no monitoring, there's no nursing, there's like, but if you have a corporate, a good practice, I don't think anybody's fasting for 12 hours.
Ma'am, there are some questions. They're asking, can spinal subarachnoid block or epidural can be given if a patient has a history of head injury with CT changes, though resolve at present?
I mean, after how many days? Like he has a CT change, matlab, he has a subdural hematoma or EDH.
But now
So,
it has resolved. Actually, the duration is not mentioned, but the
so
patient
if
has the
your
past
CT is normal, like you repeat a CT and it's normal, you can give a neuroaxial block. But if you repeat a CT and there is still some lesion there, then I don't give neuroaxial block.
And ma'am,
And
if
I
they are
think,
given,
Urvi, I think even the auto-regulation takes time to return, even after, takes quite some time
Yeah.
after an injury. So, no, so they say almost 3 months to 6 months, I think.
Right. So a spinal anesthesia is a little risky
Yeah.
for any head injury patients. So we wait for that. Yeah, you can wait for a couple of months.
and also, which will be the best non-opioid additive for spinal anesthesia in geriatric patients? We use
I
opioid,
don't use, they're
fentanyl.
not FDA approved. We have to use what is FDA approved. The FDA approved are only, I think, 2 drugs. One is fentanyl and the other is, sorry? Fentanyl is one.
FDA approved, no? But in geriatric, we'd like to avoid. But clonidine is FDA approved, no?
And clonidine, yes, fentanyl and clonidine. We are not using clonidine in geriatric, so I don't know. I can't answer that question about which additive to give because I have never given anything else. And fentanyl is safe to give in a geriatric patient. I have given
There is
fentanyl.
an audit of a fracture hip for hip surgeries, na? What they said, the only in that, I think it's in the British journal, where they have said the only adjuvant we should use is fentanyl.
Yes. And remember one thing, whatever you give small doses, like 1.5 ml, even less, and top it up with an epidural. These old geriatric patients can't take more than 2 cc spinal drug. Then NORAD will start, and then the kidney will fail, and then they'll come to my ICU. So avoid more than 2 cc drugs. So you don't have to give NORAD only for that patient.
Any more questions? Thank you, ma'am, for that
Okay.
excellent talk.
Yeah, thank you.
We'll move ahead. Dr. Deepa Shriyan, ma'am.
Good evening, Suchita. Should I start sharing my screen or you speak?
You can share, ma'am. I will just talk a little bit about
you
you.
can start.
Dr. Deepa ma'am is additional professor at HBT Medical College and R.N. Cooper Hospital, currently managing orthopedic OT. Ma'am has a rich clinical experience of more than 20 years. Her special interest is neuroanesthesia, obstetric, and also hospital administration. During COVID pandemic, she has worked as a dean at Daisar Jumbo COVID Center. Today, madam will have a talk on pediatric anesthesia, pediatric concerns for the patient posted for orthopedic procedures. Ma'am, over to you.
Thank you, Suchita. Yeah. Good evening, everybody. Thank you for this wonderful opportunity that I've got to speak in this nice webinar that we are having. So carrying on the
Ma'am, will
topic.
you on your video, please?
I'm getting a little disturbed with the video.
Okay.
Can I just
Okay.
put off? Yeah.
Okay.
Thank you. So when we do an orthopedic practice, most of us like to shy away from those small teeny weeny bachas that come to us. But we have to be sure that we should be prepared rather that children, I mean, they will come in all sizes to us. So orthopedic surgery essentially is in pediatric patient, we have to be real. Why is this like that? I can't move my screen forward, Suchita.
Ma'am, there is a difficulty in sharing.
Wait, just a minute. Let
Yeah,
me just. Is it coming now? Yeah.
yeah, it is coming.
Okay. So we have to always be prepared and prepared and prepared. That's when we will avoid all problems. So today I shall be briefly touching upon anesthesia concerns and management for pediatric orthopedic procedures. Now, why is it so important? Most of these pediatric orthopedic conditions need to be treated immediately and adequately because the children are in the process of development. I mean, listening to all that debate that we can wait and all those things, yes, but here necessarily we are worried about that growing child. So, what are the different pediatric orthopedic surgeries that we come across? Children come to the OR for trauma, fractures. They can be polytrauma or a traumatic spine. Various congenital conditions like clubfoot, scoliosis, as mentioned earlier, or you have a bone cyst. You can have infection like an osteomyelitis, a poliomyelitis, or a tuberculous infection. There can be developmental anomalies like it's congenital CDH or a Pert's disease, which we just recently did one, and a slipped upper femoral epiphysis, which is seen in the little older age group, or the neuromuscular conditions like muscular dystrophies, progressive muscular atrophies, and poliomyelitis or scoliosis surgeries. We can also have various neurological conditions coming to us with concomitant orthopedic diseases and tumors like sarcomas and osteochondromas. You can even come across rare congenital conditions like osteogenesis imperfecta in your practice of routine orthopedic surgeries. So now, mainly, the concerns are many, but here I would like to highlight few. You would see that most of these children who come to us present with concomitant diseases that can affect the cardiovascular and the respiratory function. We are always wondering whether, I mean, this risk of aspiration is there if the child is inadequately fasted. So this is a constant debate whether I mean the surgeon will tell us jaldi le lo patient ko problem ho sakta hai, and we are like worried about the aspiration and the eventual outcomes. The another thing that we face a problem is the protracted operating time. Since the baby is small, you have a lot to lose if the operating time really exceeds than what was anticipated. Many of these patients come to us for chronic surgeries. I mean, like every time there is another a redo and more and more surgery and more anesthesia, which will predispose these patients to more problems. Positioning, one, I think it has already been touched upon with the adults. It's really important in children because they're small and most of us are really not equipped in the OT to position a child right. So all these preparations have to be done prior. Another thing is that which is routinely used is the regional blocks, but they should not mask symptoms of compartment syndrome. These all have to be vigilant even in the post-operative period. Intraoperative temperature regulation is another major concern, which is actually affected by tourniquet. So many of the things people recommend that while you're actively warming the child, you must be very careful in conditions like osteogenesis imperfecta or orthogryposis multiplex, where temperature can increase in these patients, or when you have just applied a cast. Okay, so blood loss is another important concern where giving blood, I mean, we would really shy away from giving a lot of blood in these patients. We would like to prefer strategies to reduce the blood loss. And fat embolism, I would say, is not very common in children. However, if you find a child who's getting hypoxic and is having altered consciousness in your ICU, then that must be one of your diagnoses. One of the another major concerns is the excessive use of imaging in these very young children, where multiple shoots are carried out. I mean, it doesn't seem any of our business, as the orthopedicians would suggest, but it is definitely our business, because the more number of shoots, it is going to cause problem to that child. And as Urvi has already said, NSAIDs, I think we have to be very cautious about using NSAIDs in these children too. Most of these orthopedic children pose unique challenges to us. I mean, it can be a simple surgery. The child can come to us like a K-wire or a manipulation or a simple tendonectomies, or they can be an extensive procedure like a scoliotic repair. So that spectrum is very wide for these children. And children can come with psychological issues, like if you're having a syndromic child, or if the child has had previous experiences of anesthesia, which could be positive as well as negative. So those problems are there. And something very important is communication difficulties that you would have to have with the children. It depends on the age group and the I mean, and the whatever the understanding capacity of that child, that you can suggest things, which is, it is much easier in an adult in that case. And frequent respiratory infection. We know that the weather outside constantly changes and our children come with running noses. And this is always a trouble for the anesthetist who is treating them. And excellent pain management, because it is an experience for a lifetime. Every time a child comes to you, for him, it's like, I mean, he should be treated well. He should get a good pain relief so that he remembers you ever and ever. So when you're assessing these patients preoperatively, you have to look at important comorbidities. Like you could have a scoliosis with a restrictive pulmonary disease, or congenital or acquired cardiac lesions, which may be a part of factorial. So you have to note all these, or the craniocervical anomalies or facial anomalies you may have, hydrocephalus, or a dental disease, which may increase the infection, or obesity, as in the SUFA disease, where there is a slip of the femoral head. The obesity is one of the main concerns in those cases. Pre-existing neurological deficits, contractures, deformities, or fractures should be carefully documented, because as we have already discussed, while giving regional, these documentations are very important. And while positioning the patient, or such things will aid us planning and handling the patient well. Obstructive sleep apnea, this, if there is such an history in an obese child, then this will increase the incidence of airway obstruction and desaturation and laryngospasm in the perioperative period. Previous history of anesthesia is very important to note. You must review all the anesthetic charts that are available, that will give us useful information as to how the child was dealt earlier, and if there were any complication in the past surgery, that can be taken care of this time. Beware of the location of the site. Like, you have to discuss your plan. I mean, you have to sit the surgeon down, because every time it's a new experience for us. So the length of the procedures, where he's going to put, sometimes even they are not very sure what they're going to do. But I think we must discuss the plan out. That way we also can make our own plan, because multiple intervention in one session significantly extends the surgical duration, and thus the analgesic requirement. Like, you may have planned for something, but intraoperatively he changes his plan, the surgeon. Then we need to fortify our analgesia. A focused examination relevant to the history that has been given has to be done. Intravenous accesses may be difficult in children, so we can take help of our pediatric colleagues or the ultrasound machine, or maybe get the, as Urvi rightly said, we cannot keep the patient very dehydrated, which will make our intravenous access even more difficult. So one of the main concerns that most of us have is the upper respiratory tract. So LRTI can have increased sensitivity for up to 6 weeks after the upper respiratory symptoms have resolved. So actually, ideally, we should wait for 6 weeks. but increased risk of increased risk of perioperative laryngospasm, bronchospasm, and oxygen desaturation is seen within the first 2 weeks after an upper respiratory tract infection. So this is a very crucial period. We should delay surgery if we see that the child has a fever of more than 104 degree, purulent nasal discharge, that the color of that discharge is very important, and behavioral changes. The child looks lethargic, toxic, and is not feeding well, or a wheeze is present, then we definitely need to delay an elective surgery. A clear nasal discharge in an otherwise healthy child, like morning, he is just snuffling a bit or he's cried a little bit, I think we can still proceed with an elective surgery. So what are the investigations that we need to do in children? Basically, if the child is fit, healthy, and has a minor procedure, then you don't need to do any laboratory investigation. Those undergoing major blood surgeries, at least a full blood count with grouping is necessary. Investigation of all the systemic, like the cardiorespiratory diseases, is best done with a consultation with a pediatrician if you require, or the other specialties like chest physician. You can rope in whoever. I mean, as long as you are comfortable that the child is, you know exactly what are the problems with the child. Screening with a pulse oximeter, if there is a concern with a cardio respiratory disease, is a good practice when you go for your pre-op rounds. Now, starvation in children is standard, but children with acute fractures or complex comorbidities may have delayed gastric emptying. So may require, ERAs, I think they are trying to establish in children, but they're finding it difficult because, you have to explain to the child. There's a lot of, I would say, stakes in the circle. So that way, you need to keep in mind that they can have delayed gastric emptying, and you have to supplement maybe with an IV fluid if you have fasted the patient longer. Urgent orthopedic surgeries must be determined, which may actually take precedence over the appropriate pre-surgical fasting time. So if there is a fracture which needs, and there is a nerve injury or compression, you may have to actually do the surgery earlier than the fasting hours. Now, anxiety is a very important problem in this age group, because most of the times they may not be crying because of the pain, but because they are anxious. You would find anxiety more common in age group between 1 to 5 years, and children who are shy, who have had a poor medical experience, and their parents themselves are very anxious. So post-operatively, this will affect whatever the pain scores are. They may be higher. You may require more medication, pain medication, to calm the child down. And if you have just put the child in an ICU in the post-surgical period, then it's like the worst thing for them. So how do we mitigate this preoperative anxiety? We can go, get friendly with the child, talk to the child, make him watch some videos, or, tell some stories. Parental presence during induction in the beginning while we are taking an IV line is a good practice. Anxiolytics like midazolam work excellent to allay anxiety in these children. Simple things like pain relief. I think earlier it was mentioned that sometimes the child is just crying. They can be, giving some analgesics, and then when the pain stops, the child is pretty okay. Use antacids, prokinetics, and drugs to reduce secretions can be also given as pre-med. Applying EMLA over the IV site is a good practice, along with, if you are going to planning a caudal insertion and all, you can apply EMLA preoperatively. That will help you do the work. So for us, induction of anesthesia, we feel, oh, that's a pretty nice picture where the child is looking at the, he's feeling happy with the inhalation. But the child's view, it may not be so. It may be quite traumatic for the child. One of the induction agents that is good for the children is sevoflurane, because it's less pungent, less irritating, and the odor of sevoflurane can still, however, upset the children. So use of nitrous oxide concomitantly, which is odorless and provide rapid anxiolysis and sedation, can be considered. External stimulation like tourniquet application, like the surgeon is trying to do something when you're gassing the patient, trying to dressing or trying to remove the cast. During that excitable phase, it's best not to do because you may land up with a laryngospasm. IV placement and airway placement should be performed after the excitement phase is over and you have given sufficient drug. Contraindications to inhalational induction is also present, which includes malignant hypothermia in few cases and full stomach, or if you have a difficult airway or cardiac condition. So prior placing of IV is mandatory. Intubation should be considered in children with reflux. Use of LMA currently is in practice. Positioning requires utmost care in patients who have limb deformities and contractures. Padding pillows and special frames, especially when you're proning the patient or if you have pulled the patient to apply a cast, you have to be very careful that the child is not getting pushed. Sometimes even the rolling of the clothes can leave marks and injuries to the child. When it comes to most anesthesia, we have to use our neuromuscular blocking agents. So children with neurological or metabolic component in these children causes an altered response to the neuromuscular blocking agents. Scoline, for example, has to be avoided as it causes hyperkalemia, and also there is fear of malignant hypothermia. Especially in arthrogryposis, where there is an underlying myopathy that is seen, and in achondroplasia, where an upper motor neuron lesion is accompanied, or in osteogenesis imperfecta, where the added fasciculation can actually cause more fractures. Shorter acting non-depolarizing agents with neuromuscular monitoring should be ideally used in these children. So plan for pain management is multimodal, and multimodal. You can use pharmacological adjuncts along with to your narcotics, or you can use regional anesthesia, which decreases the need for systemic pain management. Decreased opioids use can minimize the side effects and complications such as nausea, vomiting, constipation, which we know. I think acetaminophen is very used a lot of times in these children. They are administered orally, rectally, or IV. You have to be aware that some of the oral preparations of narcotics that are given to children have an added acetaminophen. So all previous forms have to be noted so that these children do not get into overdosing and result in hepatic failure. NSAIDs are not, preferred because they affect both platelet adhesion and aggregation, and thus increasing the bleeding times, and must be given in caution in surgeries which are high risk for perioperative bleeding. NSAID also affects bone formation via their actions through the prostaglandin. However, when a subset of healthy children undergoing idiopathic scoliosis was studied, no adverse effect was found with the use of ketorolac. So it still remains debated whether it really affects the bone formation. Opioids are still used in moderate to severe pain. It can be given need-based in the ICU or in the postoperative as the nurse-controlled analgesia or patient-controlled analgesia after understanding, the patient's age and the cognitive abilities. Oral opioids is known to undergo metabolic through the hepatic cytochromes. So they are converted into their active forms. Hence, codeine and tramadol are contraindicated in all children under age of 12 and for children with obesity, sleep apnea, and severe lung diseases, because it may just make them more sedated and create all the complications. Regional anesthesias, catheters are contraindicated in patients with spina bifida, or if there is a raised ICP or coagulopathy, or if there is a site infection. Attention should be paid to the total dose that you're administering, the rate of administration, and the site of injection of local anesthetic, and the use of vasoconstrictors, especially during regional anesthesia. Local anesthetic doses should be age, weight, and physical status and the area where it has to be given based on those things. If you look at the drug dosage, then large volumes of LA may be required for some blocks or some. So in those cases, you have to lower the concentration because ultimately the amount of drug has to remain the same. So easy approximation would be like 1 ml per kg of 0.25% of bupivacaine can be given. Or local anesthetic should be reduced by 30% for infants less than 6 months, where bupivacaine less than 0.3 milligram per kg per hour can be given. Caudal blocks is widely preferred in pediatric orthopedic practice. It is appropriate for surgeries of the hip, leg, knee, and foot. And a single injection or catheters can be threaded up to the desired level. If you find it difficult to use a caudal catheter, a lumbar catheter can also be placed from in this region. There's this important thing whether peripheral blocks you use a nerve stimulator or ultrasound. But I think ultrasound wins the battle when meta-analysis of 15 randomized RCTs of ultrasound versus nerve stimulation for nerve catheter placement showed higher success rates with ultrasound and less risk of vascular puncture. USG also allows us visualization of needle position and distribution of LA. USG decreases the volume of medication that is needed for a successive block and thus toxicity, which is our main concern. Because if you are getting the nerve, exactly your volume of drug will automatically go down. Poor patient cooperation, needle phobia, and inability to lie still. It makes it difficult to perform regional anesthesia in an awake or a semi-sedated patient. Unexpected movements can cause inadvertent injuries and complications. Thus, regional anesthesia in pediatric patients have to be performed under general anesthesia. Risk for neurological and toxic events were higher in awake or sedated pediatric patient compared to that with general anesthesia. I mean, I think arguably we know why, because of the movements and that needle, which is like you have a real narrow margin of safety. Most of us, I think earlier there was a debate that how would you know if there is an injury or not? But here you're visualizing. So I think we are more careful now. And maybe you can add a nerve stimulator to the practice. When there is a local anesthetic toxicity in children, you may not know only seizures and cardiovascular signs can, like tachyarrhythmias or complete collapse, may be the first time symptoms in these children. In anesthetized pediatric patients, earlier signs of intravascular injection from a test dose can be an ECG change, such as a peak T waves, or an increased blood pressure. Highest risk for severe LAS seems to be in infants less than 6 months of age. Compartment syndrome is another problem. If unrecognized, can result in muscle ischemia and limb loss in these children. If you see that the child is suddenly getting agitated, anxious, or if the analgesic requirements are gone up, then these are signs of could be signs of compartment syndrome. Currently, there is no evidence suggesting that regional anesthesia would delay the diagnosis of compartment syndrome in children. Increasing breakthrough pain from a working regional anesthetic, however, should be pathognomonic. So like you find that, oh, the child was comfortable as of now with my epidural dose and suddenly wailing away, then maybe we should look for acute compartment syndrome. So how do you strategies to minimize these complications would be that identify the patients who are at high risk, such as those who are undergoing tibial compartment surgery, use dilute solutions of local anesthetic, and cautious use of additives to decrease the density of the block. Appropriate monitoring of symptoms have to be done, and measurement of compartment pressure if compartment syndrome is high on suspicion. Here we have seen that I mean, this is one nice case report that I found after we recently faced with this problem. Like one child suddenly had a hyperthermia and everything looked fine. I mean, we did have a malignant hyperthermia scenario crossed our minds, but then we realized that, a tourniquet and all those things could have been, and heating the patient actively could have been the bigger problem in this case. So, tourniquet is one thing which can cause hypothermia in pediatric children. And it is a forgotten association, I would say, because adults really don't show so much of rise in temperature. So temperature increase is greater with bilateral tourniquet, and children requiring tourniquet should be not aggressively warmed. So like you don't put the warmer, like that is our practice, most of us. Pediatric means we have to start the warmer. So at least be aware that if a tourniquet has been applied, then we should not aggressively at least warm the child, or maybe keep a constant watch on the temperature. Now, there are specific conditions which require orthopedic surgeries. So, like there are some syndrome, something like cerebral palsy. Patient can come to us with various orthopedic surgeries. So, the anesthetic implications are these people may have cognitive, communicative, and behavioral disorders. Epilepsy may be seen in 30% of these children. They have gastrointestinal reflexes, which cause recurrent respiratory problems, drooling of the saliva. So maybe use of LMAs and all may not be a good idea. You have to put in a tube. Poor nutritional status, electrolyte imbalance or anemia. So losing blood. I mean, there is a very narrow margin of safety here. Respiratory problems like poor respiratory reserve, subclinical they have some amount of aspiration all the time from reflex. So they could have chest may not be really clear, and recurrent respiratory tract infections may be there in these children. So poor dentition and dental caries and loose tooth are potential for bacteremia, and during airway instrumentation has important implication for children receiving metal implants, because you don't want that infection to reach the implant. And so we have to take care of these caries before we take the patient up for surgery. Temporomandibular joint dysfunction may make our intubation difficult. Autonomic neuropathy and poor control of temperature and blood pressure is also a problem. And intraoperative hypothermia is common, compounded by loss of lack of fat and muscle in a malnourished child. Difficult IV access may be due to spasticity and dystonia in these patients. The other group of patients who come to us are the ones with neuromuscular disorders. All the major surgeries should be discussed with the neurologist or the pediatrician before the surgery. All medications should be continued preoperatively and restarted as soon as the surgery is over. Anesthetic risk related to airway, respiratory impairment, poor myocardial function, gastrointestinal reflux, and abnormal drug reaction, primarily malignant hypothermia and excessive bleeding in certain myopathies like Duchenne's, where suppose you have a patient in for a scoliotic surgery, then with the concomitant Duchenne's, then more than 2,000 ml of blood can be lost in these patients. Formal sleep studies are indicated are indicated to access the need for NRV support in the postoperative. So if you have an OSA patient, as I explained, there are some category of patients who are obese children nowadays, and childhood obesity is becoming more and more common now. So if you need a pre-op overnight oxygenation that or NRV support, you must know it with your sleep studies. Progressive degeneration of cardiac muscles resulting in conduction defects and cardiomyopathy may be associated with these children. Dysphagia and decreased gastric motility is common. Sedative pre-medications, if you are using it, you should be cautious. Tiva with propofol and remifentanil is effective, and avoid muscle relaxants if possible. Safe for these patients, and provided cardiac function is not severely impaired in these children. Avoid large doses of opioids perioperatively. A regional anesthesia block is often technically challenging in these children because of the anatomical problems. Hyperthermia may occur due to increased muscle activity seen in the myotonias and the iatrogenic causes of malignant hyperthermia. Increased sensitivity to non-depolarizing muscle relaxants are seen. Succinylcholine should not be used. Tiva or spinal anesthesia with sedation are preferred for muscle biopsy, which is one of the surgeries that these patients come for. Few categories of pediatric orthopedic surgeries that we face are first and foremost trauma of fractures or trauma. You see that almost 21% of the fractures that come are femoral shaft fractures. The rest of the fractures that we see are the tibial, the humerus fractures, or the radius ulna fractures. They are treated non-surgically with traction or simple casting. Sometimes we are called in for a sedation or a TIVA because the child may not allow these say a cast. And fractures are also manipulated under anesthesia. Most common pediatric orthopedic procedures that are undertaken are the trauma fractures, and potential intracranial, cervical, chest, or abdominal injuries should be evaluated when we are looking at trauma of the long bones. So bleeding, hypovolemia need to be assessed, and maybe you need to fluid resuscitate these patients before you take them for surgery. Airway management with rapid sequence intubation may be mandated in some cases. Pain management with regional anesthesia may interfere with post-operative evaluation of nerve injury and motor functions, which we must be mindful of. Other surgeries that come for are the osteomyelitis or for septic arthritis. Infection within a joint in an is an orthopedic emergency and require urgent open or a arthroscopic wound wash. So that's basically a treatment that they are doing. And these children may be chronically unwell, anemic, with poor nutrition and impaired clotting that can be seen in these children. Application of hip spica, anesthesia is usually required while you apply a hip spica. In small children, hip spicas are applied with children at the edge of the table. So you may have to keep, sometimes there is very little head support. So you have to be very careful that you have not yanked the tube, because while pulling and pushing, there are chances of accidental extubation. Your circuit has to be sufficiently long enough while the child goes to the edge of the bed. The goals of anesthesia should include hemodynamic stability, appropriate anesthesia, and safe patient positioning is important. Consider intubation in a child who weighs less than 10 kgs, particularly as abdomen may be compressed during the application of the spica. So you must always see after the spica is applied that there is no compression. Remain vigilant and ensure that the airway is secure. Slip upper femoral epiphysis. This is due to the weakness in the growth plate that results in slippage of the femoral head from the rest of the femur. So the SUFE is an orthopedic emergency if the child presents acutely with the further slippage and may result in occlusion of blood supply to the femoral head, resulting in an avascular necrosis. It is associated with obesity and hypothyroidism. So you need to check for the thyroid levels in these children. Preoperative investigation should therefore include full blood count, urea and electrolytes and BUN and thyroid screening, and group and screen for blood. The next common surgery that comes to us is the club foot. It is treated by the Ponseti's method, which involves a series of foot manipulation and casting and a tendoachilles tenotomy and bracing. It is performed in children between the age of 4 weeks to 12 weeks under sedation or GA or spinal anesthesia. Caution for postoperative apnea, regardless of the anesthetic type, should be there taken in full-term neonates as well as preemies who are less than 6 weeks. Otherwise, you may have you need to keep these patients in the hospital for an extended stay or an overnight stay. Extensive surgery can be performed under general anesthesia with a neuroaxial or a sciatic block in these children. Now, the most important surgery, I think we have done quite a bit of it, scoliosis discussion in the earlier lectures, but I'll just touch upon few pediatric implications of this. Most of the times, it is the posterior fusion that is done. Okay, the anterior fusion is done once the child grows a little older or may not be touched. The children with severe scoliosis are at much higher risk due to the impaired cardiorespiratory functions, because depending when the scoliosis has set in, you may have a lot of respiratory dysfunction in these children. They may be underweight and they may be anemic. And considering that this surgery causes a lot of blood loss, anemia is a very important thing that we should watch for. Otherwise, we may face difficulties in the post-operative period. A thoracotomy may be sometimes required, and lung collapse to optimize the spine is necessary. The repair is usually done in a single stage. Like, this is again a debate. I think earlier we have discussed that, oh, you have a stage procedure, but maybe the orthopedician may not agree with us. For them, it is better first supine, prone, supine, prone, supine. I mean, we have faced this multiple times. So in these cases, we have to watch for all the other problems. Intraoperative monitoring allows for early detection of any nerve injury and a chance, still have a chance to reverse those injuries. So neuromuscular monitoring are usually combined with somatosensory evoked potential, motor evoked potential, and electromyography. Wake-up test still remains the gold standard, and sometimes when you're stuck with your SSCP and monitoring, you can still go back to your wake-up test. Direct cord or nerve injury from instrumentation are seen in these patients. Inhalational agents depress the neuromuscular monitoring signals to a great extent, and that's why IV anesthetics are preferred. A wake-up test assesses gross motor function and may be used to confirm persistent SSCP and MEP changes. Reducing anesthesia depth during wake-up test may result in accidental extubation, intraoperative recall, or post-traumatic PTSDs in these children, or an air embolism, inadvertent air embolism. So we must be very careful and vigilant during these tests. Since we've spoken about a lot of blood loss in scoliosis, so I have some numbers here. So they say that 750 to 1500 ml for posterior fusion of idiopathic scoliosis is seen, which is almost 65 to 150 ml per vertebrae. Patients with cerebral palsy have a slightly elevated blood loss. Duchenne's muscular dystrophy, as I said, has the highest blood loss. And other factors that are associated with increased blood loss include male gender. I don't know why that is, but definitely degree of kyphosis, and the operative time that you've taken, if the lower body mass index is there, and if you're trying to fuse number of multiple levels, and if the corpse angle is greater than 50. So we have put in various strategies to decrease blood loss. Preoperatively, we know that preoperative iron and erythropoietin therapy must be given. You may have to give intravenous therapy, preoperative autologous blood transfusion and donations, which I think people must be wondering, like, can children actually donate? Yes, you bring up the HB and then, you donate and then use it. So again, to remove blood, that has to be done, just after induction prior to surgery. So that way, and then fill up and maintain the volume in the child. And intraoperative blood salvage techniques can be used. And other intraoperative strategies are controlled hypotension, normovolemic hemodilution, and use of antifibrinolytics. So what they found is the most effective techniques are the intraoperative blood salvage techniques and use of antifibrinolytics. So tranexamic acid is known to and perioperative bleeding in children. Like, what do we still know about it? Tranexamic acid is now recommended in the recent guidelines as important part of pediatric blood management protocols. 10 to 30 milligrams per kg loading dose followed by 5 to 10 milligram per kg per hour maintenance infusion rate for pediatric trauma and surgery is seen. Side effects are rare but could include seizures and thrombosis. Better dosing regimes are warranted to avoid unnecessary high concentration and subsequent complication. So actually they're still working out the best, but I think with this dose, less complications have been seen. As we've already discussed, the complications of positioning in these kids, padding on the pressure points to minimize the screen breakdown, peripheral neuropathy such as brachial plexus injury or the ulnar nerve is seen, and reevaluate the arm position in between the surgery. So it's like not done and dusted. We have to constantly revisit. I mean, I think we have to almost be paranoid about positioning. That's when you can really do a good job. Visual loss is another very important complication which is seen in spine surgery. So the incidence of visual loss in pediatric spine surgery was estimated to be 0.29%. Cortical blindness is predominantly seen in pediatric population. The risk factors for pediatric blindness included younger age, males, and fusion of more than 8 levels, and pre-existing iron deficiency anemia. You need to avoid hypotension and anemia and increase crystalloid administration, long surgical time, and a head down, steep head down position. Frequent checks on the eye are needed to prevent inadvertent pressure on the globe. Thus, I would conclude that by understanding the pediatric orthopedic surgical concerns is necessary to get an optimal outcome in these patients. Thank you very much.
Hello.
Yeah.
But just one question. What about spinal in infants and young children? Meaning anything about that?
Yes, ma'am. They have given spinal. You have to use drug doses of 0.8 milligram per kg. So little higher, but then the duration is shorter. Okay, so that is why you have to have a quick surgeon. Otherwise, if you're trying to you want to prolong surgery, it is not possible. The surgeon also has to be relatively quick. But they have been used amply. People use a lot of spinals. Even in India, I would say.
Areas, and I know people, outside Mumbai, where
Yeah, use a
nothing
lot of spinals.
using spinal in and out, for pediatric patients.
And I think my earlier years of my practice, when we were working in Bhagwati, I was a resident, I have put in spinals in this patient. But now as a senior practitioner, I would fear, because after having a kid, I don't want to touch somebody's back. But I think it's wonderful in a patient who is sick. You don't want to manipulate airway and everything. It is good.
So why not go for epidural?
That's what epidural again is not very definitive, and maybe you may have more problems with epidurals. Why? According to because no, madam, this is, I don't know, I don't have literature search for it, but positioning of the epidural catheter, if you've done using a USG and you know definitely where it is, the catheter tip, then I think we can say that we can use epidurals. Caudal epidural, one shot, is a good technique. But when you are inserting catheters, I am not very convinced that we will be able to.
We used to do a lot of cases. I remember when I was in urology, we used to do a lot of pediatric pyeloplasty and all these
Yes.
cases, epidurals.
Yes, but literature says that always you should have evidence that your epidural is in the epidural space. Like,
no, that is true. See, again, spinal, you cannot do only on spinal. You have to give GA to pediatric patients.
No, what they've recommended is use a little bit of sedation with the
that's what.
ketamine or something like that, and give your spinal. Or put EMLA. EMLA is wonderful. Like you put an EMLA and then you can do your spinal back, so that at least you don't have to clean up.
No, but you need the patient to be immobile. Na? The child, you are given spinal.
Or if you gas the patient or you give TIVA, I think that should be good enough.
Yeah, but analgesia is again a problem, na? So you need to put something, LMA or something, na, in these patients.
Yeah.
Huh?
I don't know. The literature doesn't mention particularly putting LMAs or things like that. They have mentioned that people have done under spinal. Now, how much they do, that's
how they have done. Because what happened tomorrow, everybody will do, but you have to know how they have done under spinal. Na?
Not a lot of reports are there, madam. They have only done.
Reports are there. And that's what I'm saying. But what is it says?
Studies where they've said that they give a little bit of sedation and then they put the spinal, because they're like short manipulations now, and maybe a small tenotomies that or K-wiring. They have done such things. They have done. And as madam was already saying, lot of people out of Mumbai are practicing spinal anesthesia even in kids. Even neonates have been mentioned. Even in Mysora or our Smith.
Oh, they are mentioned, but how they are doing and how safe it is.
That's what I said. The drug dose will be higher because you have to calculate properly. You have to have a fast surgeon. You have to discuss with your surgeon and obviously be ready for any hypotension that will occur or with a tube or things like that. Maybe minimal setups which have minimal access to things, they use spinal.
In fact, they should not use.
Yeah, I agree.
And they have minimal resources,
Yeah.
As I told you, the resources they are using.
Yes.
With only they are using.
Right. Resource poor people are using it. Yes.
But I feel
And
resource
many of them
people.
don't even use spinal needles. So they will use a BD needle, with a small syringe and then give the spinal.
See, once you're
What
entering the,
Pardon?
if it's resource poor center, then again you're worried about infection, everything.
Yes,
Then you're
yes,
intrathecally you're administering drugs.
yes, yes,
So you have to be more careful.
yes.
Right. And secondly, about that neuromonitoring you said,
Yes, ma'am.
above what age or below what age? Means up to what age you can use, above.
Neuromonitoring can be done in all ages from infants to adults. Like in
Hmm.
infants under 12 months, like you will require more baseline so they are higher required in these children to elicit the MEPs. Okay, so in children, what happens is that the motor pathway is still developing and it is not fully developed, so higher delivered charge is needed. And in
Higher
adolescents,
stimulus.
yes, stimulant current.
Hmm.
So you can actually do it from all ages, from infants to adults, everybody, neuromonitor. Only
Means
that you have to be very vigilant.
what?
Pardon?
You said infants. Smallest age is what you can do neuromonitoring.
Children under 12 months also it has been done, madam.
No, what about below 3 months or something? Is there any this thing?
No, madam. I have found that up to 12 months people have done. So below that, I didn't find any reports.
Then any questions? And how much volume you said? But see, like adults, we know that in interscalene you give 15 ml. In axillary, 3 ml in each of the nerves. But in pediatric, how much do you give?
So you just reduce 30% of the doses. That's what they say. So then you
Dose means
calculate.
that's not volume. That is the dose you said. I'm asking of the volume.
Yeah, volume that again it depends on how much you require, but definitely they've said use lesser volume. Nowhere I've got these numbers where you can say, but as I said, that 1 ml per kg, that much volume you can use arbitrarily. Like 1 ml per kg, suppose it is a 10 kilo bacha, then maximum you can give 1 ml per kg, and but you have to dilute the dose to 0.25%. So then
1 ml per kg of what concentration?
0.25% concentration.
Okay, so that come 1 ml, 10 ml means 25 milligrams.
Yes, 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 yes.
One
like
ml
that,
per
I think what we can do is weight-wise is 2 milligram per kg.
yeah, 2 milligram per minute.
Then you dilute whatever concentration you want. That is safer.
Yes. So 2.5 or 2 that we have follow for the adult, the same formulas we follow for the kids.
Yeah,
Only
that's
that
what.
concentration, since you require more volume and the amount concentration is higher, you dilute it. That's what. Suppose you require like in a block, suppose you're doing an axillary block. I think in a child who's 12 years, you would require like say anything between 10 to 12 years, right? So 12 ml volume. But if you would have calculated as dose, it will be much less. So you'll have to dilute it to get that volume.
Yeah, anyway, there is no problem because you have anyway given GA to the patient. It's
Yes,
not the
yes.
sole anesthetic agent you're using.
That's what I said. 1 ml per kg arbitration is fine.
What about peripheral nerve stimulation? How much current for pediatric? Is it same or like we go down up to 0.5?
Yeah, they have said to go up to 0.2, go below 0.2 also current. That you should not see as a in pediatrics. That's what when we go down, no, we go down up to 0.5, no?
0.5.
Yeah. They have said
0.2 is more close to the nerve, na?
Nearer to the nerve.
Yeah.
yeah,
And
that's what I read, that they said that go down the current more. I mean, you can use a peripheral nerve stimulator and the current you can go down more. That's what they said. But I personally have never used PLS for this. From blind blocks, we have directly come to USG guided blocks. So I think USG is the way forward. I mean, unless we are doing those caudals and all, where I think, or a sciatic, where we are in a deeper block, PNS can be more useful.
any other question?
I think there are no questions in the chat.
Any more questions?
No, you can call it a day.
Thank you, Deepa ma'am,
Thank you, Sucheta.
for that excellent talk. Uh, this this was the last lecture for this webinar. I thank all the excellent speakers and expert moderators for such a informative talk and making it an interactive session. I thank ISA Mumbai Metro Branch along with Department of Anaesthesia, HBTMC and RN Cooper Hospital. Also, I thank SAMS, that is the Society of Anesthesiology Maharashtra State, for organizing this webinar. Last but not the least, I thank all the participants to attend this webinar in such a great number and making it a success. Thank you.
Thank you to all the faculty. Thank you, Sucheta.
Thank you very much, ma'am. Dr. Yogita, can we leave?
Yes, yes, yeah, we can leave now. Good
Yeah,
night,
thank
all of you.
Thank you, Dr. Yogita, for helping us out throughout. Thank you.
Good night.
Thank
Good night.
you. Good night, everyone.
Good night, all. Yeah.